Good morning. Welcome to the American Society for Preventive Cardiology's Imaging Symposium. It's Multimodality Cardiovascular Imaging for Prevention, Essential Insights for Clinicians. This is a complimentary educational initiative produced by ASPC and later will be available to view on aspconline.org as well as our YouTube channel. I'd like to thank everyone in advance for completing the pre- and post-session surveys that you should be able to see. My name's Alison Bailey. I'm a cardiologist and the vice chair of the cardiology department and chief of non-invasive cardiology at the Heart and Vascular Institute at West Virginia University. I'm joining you this morning from Morgantown, West Virginia, and I'm so excited to introduce my co-chair, Dr. Leandro Slipczuk. I'm going to let him introduce himself.
Hi, everyone. Thank you, Alison. So happy to be here with you. I'm Leandro Slipczuk. I'm a preventive cardiologist and imager and the assistant director of non-invasive cardiology at the Khurram Health System in New York. We're really excited for everyone to be joining us today on a Saturday morning where you could be doing a lot of other things with your time, but hopefully we'll make it worth it. Today's program is all about the growing role of cardiovascular imaging in prevention. As we continue to look for better ways to detect disease earlier, refine risk assessment, and personalized care, imaging has become an essential part of the conversation. Over the next few hours, you'll hear from an outstanding group of world experts who will share practical insights on how different imaging modalities can be used in everyday clinical practice. Our goal is to make this content not only informative, but also immediately applicable, something you can take back and use with your patients right away. Whether you're joining us from clinical, research, or broader healthcare background, we hope this symposium gives you new perspectives, sparks ideas, and helps advance the important work you're doing in preventive cardiology. Before we begin, we'd also like to recognize support received from our industry partners that help make this program possible. Thank you, Clearly and Harplow. Thank you again for being here. I'll turn back over to you, Alison, to introduce the next session.
Thanks, Leandro. So we're going to start at the beginning this morning, and that really is coronary artery calcium, the prevention workhorse. We're going to hear from Dr. Michael Blaha from the John Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease, and he's going to be talking about when to order, how to report, and how to act. Following Dr. Blaha, Khurram Nasir from the Houston Methodist DeBakey Heart and Vascular Center and the new editor of our Journal of American Preventive Cardiology will discuss CAC in 2026. And from risk marker to risk modifier across guidelines and phenotypes. And then lastly, in this first session, we'll hear from Parag Joshi from UT Southwestern Medical Center, who will talk about CAC and cardiometabolic risk, diabetes, chronic kidney disease, women, and the paradox of normal LDL. Following Dr. Joshi's lecture, we'll have an opportunity for audience questions and discussion with our three presenters. Without further ado, I'll turn it over to Dr. Blaha.
Hi, my name is Michael Blaha, and I'm from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And thank you so much for the invitation to speak at this ASPC Imaging Symposium. I'll cover the topic of coronary artery calcium, why, what it means, when to order it, how to report it, and a very quick section on how to act. And this will serve as a general introduction to the topic that further talks will go into more detail. So let's jump right in about why the coronary calcium score. Why do we need a calcium score at all? Well, of course, as we know, risk prediction is very hard. Here's the distribution of risk factors in the population. You can see that very few people have truly optimal risk factors, and many patients in the population in the middle-aged adult population live in the borderline to elevated risk factor zone. Now, when you look at the relative risk of cardiovascular disease across these groups, of course, it goes up even in the borderline risk factor or elevated risk factor zone before you get to the multiple elevated risk factors. But when you integrate these two curves, you get the core problem of preventive cardiology, which is that most cardiovascular deaths occur in the middle. Because there's so many people in that borderline or elevated risk factor zone in the population, a majority of first ASCVD deaths occur in this zone in patients that aren't clearly high risk, but have borderline or an elevated risk factor. So the question always is, how do we best identify these patients? Now, Our guidelines would have you start with the 10-year risk model, right, to measure risk factors at one point in time in middle age and project out, for example, 10 years to see who's at ASCVD risk. But from an imaging perspective, from the perspective of this symposium, this is not ideal because we know that atherosclerosis can accrue over a lifetime with risk factors that change and once again accrue over the entirety of the life up until that assessment. And of course, we care about risk beyond just 10 years, but over the lifetime of the individual. So many people have tried to improve upon risk prediction, upon, let's say, a risk score like the PREVENT risk score by adding genetics or the environmental factors or biomarkers to the risk score. But we still don't have perfect risk prediction. In fact, there's so many things that drive ASCVD risk, from genetic factors to environmental factors, that it's hard to even measure them all. Many of them are unmeasurable. Sort of the appealing strategies is to use subclinical atherosclerosis as a final common pathway before an ASCVD event that integrates all the upstream measurable and unmeasurable risk markers and make an assessment of risk. So subclinical atherosclerosis, once again, is the neck of the funnel that is the final common pathway before an ASCVD event. So an imaging-based approach to risk prediction looks more like this. Can we use a tool that integrates risk exposure over the entirety of one's lifetime up until that assessment with measurable and unmeasurable risk factors in their interaction and project out both 10 years and over a lifetime of the individual? That is the promise of the subclinical disease detection model. And that is the rationale for why we need an imaging test like a calcium score. So coronary calcification, what is it and what does it mean? Let's talk about some basics of calcium. Well, it's been known for a long time that calcium within the coronary arteries is indicative of coronary atherosclerosis. This dates back to the Renaissance, when it was described in anatomic specimens that palpable coronary arteries were present in patients who seemingly died of a heart attack. And of course, in the imaging era, we knew from chest x-rays and then the cath lab that calcification detected within the coronaries was a predictor of coronary artery disease, obstructive disease on a cath, and all-cause mortality. And of course, now we know that calcification is an exquisite marker of atherosclerosis. Particularly within the coronary arteries, calcification is pathognomonic of coronary atherosclerosis and can occur as early as the second decade of life in high-risk individuals like patients with familial hypercholesterolemia. There's some rare exceptions, include calcium handling disorders, but most everyone who's got calcification within the coronary arteries has coronary atherosclerosis. And of course, the key finding that was described in the 90s is that there's a direct relationship between the amount of coronary calcium and the total plaque burden. And that's what's shown here. From the early studies, there was a direct relationship on autopsy on a histologic specimen of the amount of calcification being directly proportional to the amount of plaque. When 38 patients were placed on a log linear scale here, this seminal observation was made that the amount of calcium is directly proportional to the total amount of plaque. So calcium scoring, or calcium within the arteries, is a marker of total plaque burden and is a simple form of this subclinical disease detection model. So once again, coronary calcification is a marker of coronary atherosclerosis that has very high specificity for at least some coronary disease, but as we'll see, also has a very high sensitivity for clinically important coronary disease. In other words, it has a high negative predictive value when the calcium score is 0. But actually, it's a poor marker of obstructive CAD. It's really a marker of total plaque burden. And these things on the page drive exactly how we use it in practice, as a prognostic tool, but not a tool to drive people into the cath lab or stress testing. And it shouldn't be used as a surrogate of obstructive CAD. It should be used to drive medical decision-making. Okay, so how do we actually do this calcium score test? Right, well, of course, it's a non-contrast cardiac gated CT scan that can be done within minutes at about 1 millisievert of radiation. And you get images that look like this. These are non-enhanced images of the heart. Those things that are bright are calcium within the coronary arteries that stand out at you. And all the operator needs to do is confirm indeed that that calcification is within the coronary arteries and not within, for example, the pericardium or the valve apparatus. And software will give you a calcium score. And again, the calcium score is directly proportional to the total plaque burden. So the calcium score is done the same way around the world, the same scanner settings, and reconstructed the same way and scored the same way, which makes it a highly reproducible and portable test around the world. Once again, that can be done in minutes. And this is how the Agatston score is actually scored. The calcium score that we use is called the Agatston score, and it's a summed score of all the individual calcium lesions within the coronary tree, with each lesion being a function of the area of calcium and the density of that calcium. So calcification is defined by contiguous voxels above 130 Hounsfield units, and you weight that calcium more by the density, as you can see here in Hounsfield units. So you can see a calcium score on the left. This plaque in the LAD is 15 millimeters squared in area. Peak CT attenuation is 450. That would be 60 Agatston units. And on the right, a younger plaque in the right coronary artery, 8 millimeters squared in area. Peak CT attenuation is 290. That would be 16 Agatston units. And if these are the only two lesions in the coronary tree, that would be a score of 76. That's the way the Agatston score is done. It's extremely simple to do. A scan could be read in 1 or 2 minutes by design. Now, remind you that, of course, the calcium score is only detecting calcified plaque, but calcified plaque is a sign of the total plaque burden. So naysayers will say, well, you could only see the calcified plaque, you can't see the non-calcified plaque, but we know that calcium is commonly present in nearly all maturing plaques. And with increasing calcium, there's increasing plaque volume. So the calcium score is really a surrogate of the total plaque burden, even if the non-calcified plaque can't be seen. And of course, the calcium score is a strong predictor of events. This is from the multi-ethnic study of atherosclerosis, showing that if you're young and have a high plaque burden, high calcium score, you have a high event rate. And if you're an older patient who's got a low calcium score, you actually have a low event rate. So it's not just age, and it's not just risk factors. This is a seminal paper from Dr. Khurram Nasir, showing that if you have no risk factors but a high calcium score, you have a high event rate. And if you have multiple risk factors but a calcium score of 0, you actually have a low event rate. But not only that, the calcium score is a measure of injury within the walls of the vessels and subclinical disease. It actually predicts a variety of chronic disease outcomes, including CKD, cancer, dementia as well, because it's really can be best thought of as a marker of biologic age, of the cumulative impact of risk factors on the body. So you can actually make competing risk curves that look like this, that show that if you're young and have a high calcium score, you're more likely to die of cardiovascular disease and cancer. But actually, as this test of biologic age or injury to the vascular system, we can see that if you live to age 70, you would have a calcium score of 0. You're way more likely to die of cardiovascular disease, excuse me, of cancer than cardiovascular disease. So it's an extremely powerful tool for looking at the prognosis of patients across disease types. And we know that the calcium score is a predictor of benefit from therapy. This is from the St. Francis Heart Study. This is from the Walter Reed clinical experience. We can see that as the calcium score goes up, of course, the event rate goes up, but you seem to get a greater relative and absolute risk reduction with something like a statin, the higher the plaque burden. So once again, the higher the plaque burden, the higher the absolute risk, but also seemingly the higher relative risk with an anti-atherosclerotic therapy like a statin. So how do we report the calcium score in practice? Well, we give the absolute score, as I mentioned, like the 76 in the patient I mentioned, but we also report the percentile. Usually use the multi-ethnic study of atherosclerosis between the ages of 45 and 84 to report what the age, sex, and race match percentile for a patient will be given their calcium score. For example, this 52-year-old Black male, the score of 109, as you can see, is at the 93rd percentile. And this helps put in perspective how this score compares to other people of the age, same age, sex, and race. If you've got a younger patient between the ages of 30 and 45, you need to use CAC tools, the website www.cactools.com, to give the equivalent percentile. But this percentile complements the absolute score. The absolute score says how much total plaque there is, what's the near-term risk, but that percentile score helps to put that in perspective and also predict long-term risk, particularly in younger patients with high percentiles. So we'll tend to report, in fact, we recommend reporting both the absolute and the percentile score on all CTs. An important thing to remember about total scores and percentile scores, because people forget that the Agatston score is actually on a exponential log scale. In other words, we tend to live with a calcium score of 0 for half of our life or longer, and it can take 12 to 15 years to progress from a calcium score of 1 to 100, but then little time to progress from a score of 500 to 1,000. As such, a patient at the 90th percentile will progress like this: score of 10 at age 40, 110 at age 50, 450 at age 60, or 1,300 at age 70. So if you look back in time, calcium is detectable much earlier than many people think, and that patient will have a very high percentile. But that patient with high percentile along the natural history of the disease will show up with a very high score later in age. And this is the relationship between the calcium score and mortality. You can see that most of the risk prediction happens in those early calcium scores 0 to 300. As such, calcium can actually be detected earlier in the coronary arteries than many appreciate. Here from the Coronary Artery Calcium Consortium, showing that, for example, in men, about 20% of 20 to 30% of calcium in their arteries already in their 30s to 40s. About half of men have calcium in their arteries at age 50, and this is highly predictive of CVD mortality even at younger ages. So one tool that you can use with the calcium score is the MESA risk score. This is a 10-year risk score that incorporates risk factors and the calcium score. This is a way to understand how the calcium score changes risk. You can see a patient here that is 60 years old with risk factors but a calcium score of 0. Would have had a CHD risk score of 15% before we incorporated the calcium score. But once we incorporate the calcium score, we realize that risk is actually only 4%. And on the right, patient that didn't have risk factors but a high calcium score who's 60 years old. Before knowing the calcium score, we thought that patient's risk was 4%. But now with the elevated calcium score, we see that person's risk is 8%. You can actually download the MESA risk score for your phone or go online to understand how the calcium score can change risk estimates. Okay, so quickly on how to act. So as we've talked about, the calcium shows up in the coronary arteries with very early plaque. Not quite at the fatty streak, but after that, we start to show up with very early calcification within the coronary arteries, and that progresses over time. And it really helps describe risk over the entire risk continuum, right? Early plaque can be identified early and signal high lifetime risk. And as it progresses, you start to get patients who have just as much coronary disease as plaque as a patient that maybe is in secondary prevention. So the calcium score can really describe where someone is along the continuum of risk. And as such, the calcium score, subclinical atherosclerosis imaging in general, can disrupt the historical binary distinction between primary and secondary prevention, where we used to say someone's primary prevention up until the day they have their heart attack, and then they become secondary prevention. But now we recognize with imaging tools that there's really a large middle group that we treat in practice. Patients who have advanced subclinical atherosclerosis, for example, because they have a high calcium score, that are truly distinct patients from primary prevention and secondary prevention. It's a unique group that we treat every day in our practice. You need imaging to identify them. We need to treat them aggressively because we can actually prevent first events. And really a lot of the rest of this beginning portion of this symposium will talk about how we can use calcium scoring and other tests to identify patients with advanced subclinical atherosclerosis and treat them in a unique way. An advantage, of course, of imaging is that we can find not just these high-risk patients, but also patients that are lower risk than we thought. Right? When you have a patient who has no detectable atherosclerosis or no calcium within their arteries, they're actually a lower risk patient than we thought. So we're going to find patients who also can be more conservative in our management. So let me summarize by just giving you the guidelines and how they've changed from 2018 to our brand new 2026 guidelines. 2018, it said there's a class 2A recommendation in intermediate or select borderline risk adults. If the decision about a statin remains uncertain, it's reasonable to use the calcium score in the decision to withhold, postpone, or initiate statin therapy. But now we've graduated. We've graduated to a more clear, higher level of evidence, higher class of recommendation. Now, class 1 recommendation B, based on some randomized data, that in adults at intermediate risk and select adults at borderline risk with no ASCVD, if the decision regarding lipid-lowering therapy remains uncertain, a calcium scoring should be used to further risk stratify and guide the decision to withhold, postpone, or initiate therapy, or you'll hear in the later talks also to intensify therapy. So with that, I'll say thank you for this invitation to speak at this symposium today.
Good morning, everyone, and welcome to our imaging symposium. And I'm truly honored to talk a little bit more where coronary artery calcium scoring is in 2026, and has it really moved from the spectrum of what we consider a risk marker to a risk modifier across guidelines and phenotypes. So just to get started, as a preventive cardiologist, especially when we are dealing with individuals who are presenting without established known atherosclerotic cardiovascular disease, the key critical question, what is your risk, is paramount, because not only it will help us guide who needs treatment, but the intensity of treatment that we'll decide together with our patients, not only for the short term, but the long term. Now, looking at the current landscape, I think over the last 65 years, the foundation of who is at risk and who needs treatment has been based upon accumulation insights of risk scores that has gone multiple iterations, but mostly remains same through the Framingham risk score, the pooled cohort equation, and now, of course, addition of few risk markers in top of what we have been the traditional risk factors. However, without going into too many details, I would say if you look at the consensus on the street are that these risk factors approaches have been imprecise. Early in the first part of the century with the Framingham risk score, we were challenged by underestimation, and over the last 10 years, now it's well established that the pooled cohort equation overestimated significantly the risk among those who didn't meet criteria for statin, identification of that, and intensification of treatment. And while the new kid on the block, Prevent, seemed to have done a better job, at least from a pooled cohort equation comparison standpoint, in risk assessment. But if you start looking deeper under the hood, it seems like probably a lot of recalibration may be needed in certain situations, such as those who do not have yet been treated with statin, which is the key question, and whether the same model may work equally across different populations where recalibration may be needed. Clearly, it begs us to ask the questions, can we do better? And for many of us, I think over the last 3 decades, have been advocating, considering the fact that now we know that most of the known as well as the unknown risk factors funnel through eventually to the complication through the atherosclerosis paradigm. And of course, one of the most widely studied and established modality in this regard is the non-contrast gated coronary artery calcium testing that doesn't require any contrast. It's pretty inexpensive, widely available, takes about 3 to 5 minutes of testing, and of course associated with the low radiation dose. Now, the reason that coronary artery calcium testing has been in the pole position as far as our choices for athero imaging has been concerned, because it provides the highest value for us identifying those who are at the highest risk, which is now well established across multiple cohorts in US and Europe. It doesn't seem to bias whether you are a man or woman of any race or age groups. And more importantly, in comparison to other contenders such as C-reactive protein or carotid interval thickness or brachial flow mediation or ABI, it has been well established to provide the highest insight. Now, the icing on the cake is also a unique feature of coronary artery calcium testing, which is absence of disease, now more known as the power of zero, that has shown that it allows us the flexibility in this group as far as initiation and intensification of management, allowing us to focus where the money is, that is those with the highest risk. Now, of course, it doesn't come without controversy. Over the last decade, it has been called many things, including a worthless slogan, blind spot, Pandora box fallacy, and many others. But the power of zero has really stood the test of time, because that component within the coronary artery calcium testing has known to clarify the uncertainty that comes as far as what is your risk across risk factors and biomarker spectrum. For example, the classic paper by Seth Martin clearly showed that across the spectrum of lipid abnormalities, as you can see on the left, there is significant heterogeneity of presence as well as burden of the disease. And on the right, as you can see, across the entire spectrum of LDL, the foundational risk factors, it is truly your presence and burden of atherosclerosis by coronary artery calcium testing that relates to your risk. Once you have a calcium more than 100, you're almost a CAD equivalent. If you have a calcium score of 0, your risk is minimal, irrespective of what your baseline LDL is. And by the way, this is not only related to lipid-lowering therapies, but you can look at, I would say, LDLs or lipid abnormalities, but across the entire spectrum of risk factors. And it doesn't matter how you slice or dice the pie, the answer is the same. If you have absence of disease, you're much lower risk than anticipated. If you have a very high calcium score, your risk is much higher than anticipated. And not only that, a lot of studies have also shown in how the power of 0 helps as a decision aid. If de-risking is considered, it's truly peerless as compared to its competitors. Adding an upfront cost of $100 to $150 is cost effective as far as the strategy is concerned versus treat all. And even in large studies, although not randomized trial, it has been shown that treating a lot of individuals with the calcium score of 0 may not yield any meaningful impact as far as risk reduction is concerned. But most importantly, we have shown that irrespective of guidelines used for identifying who needs statin versus not, whether it's a US or a European guidelines, we see almost 1 in 2 of these patients will have a power of 0, and their revised risk will be much lower than the threshold where the guidelines would consider them initiating them on statin. As a result, historically, almost 6 years back, when the new guidelines came, they acknowledged the substantial work that was done as for the calcium scoring, as I have showed. But the most importantly, they acknowledged the power of 0 for the first time. And that insights also snowballed down into many other guidelines, as you can see out here, with the whole idea of being used as a decision aid. Calcium score of 0, you can downgrade the risk, withhold the statins, delay the statins, and if you have a very high calcium score, initiate the statins. But in the context now, we have the new PREVENT score. I think so we are seeing the same things as we have seen with the ESC guidelines or the prior PCE. What we see, even if you compare it to the PREVENT score, the calcium scoring improves significant risk stratification. We see the same finding. If your calcium score is 0, your risk is much lower than anticipated, whereas higher the calcium score, higher the event rates. And I think so, based on all of this accumulating data, hammering the same message, the new guidelines that came out a few months ago clearly showed the value. And for the first time, we have seen an upgrade from a 2B to a 2A. And it's very important to understand that if we have uncertainty, whether a clinical or a patient uncertainty, even if you have elevated risk enhancing factors, whether your baseline risk is borderline or intermediate based on PREVENT, calcium testing is a class 1A to help us identify who needs lipid-lowering treatment or not. But one has to also remember that wasn't clear with the prior guidelines that the coronary artery calcium testing is not one test at a time. In the range, on an average, about 28% individuals at 5 years convert to a positive coronary artery calcium score with a slightly higher event rate. And as a result, accounting for all of this new information, I think so for the first time, we also have a class 1 recommendation that in these borderline risk or intermediate individuals where calcium testing was used as a decision aid for lipid lowering therapy, If the calcium score is 0, and we have not initiated any statin therapy or other lipid-lowering therapy, it seems fine, but maybe even a better strategy to repeat the coronary artery calcium in 3 to 7 years. If you are higher risk, elevated lipoprotein A, family history, or many other things, repeat it earlier, or at an average of 5 years to redo a calcium score to reestablish the risk and reestablish the downstream management goals. Now, of course, most of these guidelines are for gated coronary artery calcium testing, but millions of non-gated chest CTs happen in the US, where we can easily, by visualization or now with emerging AI tools, identify those calcification. And as you can see in this very interesting study where these individuals were identified, the patients and the physicians were both notified. In downstream 6 months, we see almost a 10-fold increase in utilization of statins. And of course, further studies have shown that not only initiation, but it also impacts the adherence. As a result, for the first time, the new cholesterol guidelines have also recommended that these non-gated CT scans, either by visualizations or AI-based algorithms, they can be considered in decision-making around initiation or intensification of lipid lowering to reduce cardiovascular risk. That's a big positive coming from the new guidelines. And now, of course, as you can see, most of the focus so far has been on initiation, but we know that it's based on the calcium score, the risk is not static. Higher the calcium score goes from 100, where your CV risk equivalent, to 300, to where you're touching up to an event rate of 2.5% per year, and going up to a calcium score of 1,000, which is seen in about 4 to 5% of individuals, where your mortality risk is almost equal to something that you would see in a secondary population like 4-year. I think so. A major underappreciated element of the new guidelines is it's not just initiation, but targeting to goal based on your coronary artery calcium score. Those with the highest risk, if you have a calcium score more than 1,000, now the guidelines is we should be treating that at the highest risk individuals with secondary prevention, getting their LDL targets around less than 55. That may entail not only maximizing statin but also initiation of secondary agent, either ezetimibe or a PCSK9 monoclonal antibodies. If your calcium score is more than 300, definitely most of these individuals, we should ensure that they get their LDL below 70. But if they are at a high risk, although not a class 1, but a 2A recommendation of trying to achieve it even lower. And if you have calcium more than 100 or minimal calcification, even in young individuals, which would put them at the 75th percentile for their age and gender, we should try to push their LDLs below 70. Now, of course, there are still some uncertain areas that the lipid guidelines have not assured. For example, diabetes. Of course, it's well known that diabetes is not a homogeneous disease. Across the spectrum, higher the coronary artery calcium score, much higher is the event rate. And here the question may not be about initiation of statin. And if you look at the NLA guidelines, they have strongly suggested that it's reasonable to use coronary artery calcium in diabetic in order to identify individuals who may benefit from intensification of treatment. And the same goes for familial and severe hypercholesterolemia. We yet don't have an answer from the cholesterol management guidelines. But as you can see on the left with genetically confirmed FH, or on the right with severe hypercholesterolemia, higher the coronary artery calcium score, higher the accumulative incidence of future MACE. And even some of the prior work has suggested that the individuals who had the highest burden, especially a calcium score more than 100, or probably any calcification, are most likely to benefit for more intensive and potentially more expensive therapies with least access. As a result, if you look at the NLA guidelines, they strongly recommend that a presence of any coronary artery calcium scores in these high-risk individuals should be used as a decision aid for intensifying treatment. This is not just about initiation of treatment. And beyond lipid-lowering therapy, there's tons of data that shows that coronary artery calcium testing can help for identifying patients for aspirin, for PCSK9, as I've shown, and even for GLP-1s and severe hypertriglyceridemia. But specifically for aspirin, although the cholesterol guidelines is silent, but the NLA and SCCT have suggested that it is pretty reasonable to consider aspirin for individuals with calcium more than 100, balancing the estimated benefit as well as the risk. And if you look at the ESC guidelines, they are becoming more clear. If you have ACVD or a higher CV risk, probably SGLT2 or a GLP-1 monotherapy should be initiated. And they have come with the class 2B recommendation that for individuals who are moderate risk, who are initially candidate for metformin, coronary artery calcium testing can be considered as a modifier that can help us possibly move their treatment paradigm from a metformin to a more of the novel emerging cardiometabolic therapies. And I think so it makes a lot of sense, and completely agree with the authors on this editorial that in 2026, with expensive interventions for primary prevention of ACVD, be it PCSK9 or icosapent ethyl or cardiometabolic therapy, it is not only financially unwise, but suboptimal in care of these patients if we do not perform coronary artery calcium testing first. So in essence, my take-home message for everyone here today is that rather than us twisting into a pretzel using the risk scores, let's keep it simple with coronary artery calcium testing. If you have a calcium score of 0, let's focus on lifestyle. Our treatment goals can be flexible. That doesn't mean no statins. We can always start with the low to moderate dose statin, depending upon if we are thinking about lifetime risk. If you have any atherosclerotic disease, especially in the young, the process has started. In our opinion, although the guidelines have said get their LDLs below 100, I think so it is very reasonable pushing the target of 70. And if you have calcium score more than 100, almost everyone should get their LDLs below 100. If you're high risk, push them below 55, consider non-statins, control their blood pressure, consider them for statins, and also cardiometabolic therapies, especially if their BMI is more than 27, diabetic or pre-diabetic. So again, thank you so much for the opportunity to join this amazing session. And I look forward to hearing from Deepak next on how are we going to be pushing the envelope with the CT angiogram, and especially in trying to look at the changes and the interventions, not only in real life, but possibly clinical trials. Thank you so much.
All right. Well, thank you to the organizers and to all of you viewing this presentation. I'm honored to be in this session on coronary artery calcium scoring. And my task was to discuss this in the context of cardiometabolic risk factors, as well as comparing CAC scoring amongst men and women. Here are my disclosures. So you have no doubt already heard a lot about CAC scoring from my colleagues. I just want to highlight that the multi-society cholesterol guidelines endorsed by the ASPC recently upgraded CAC scoring from a 2A to a class 1 recommendation, particularly in the context of shared decision making. So in adults at intermediate risk or select adults at borderline risk, when going through the discussion of committing to a long-term preventive medication, it's understandable that patients may be reluctant to commit to that. And I think, in my opinion, that imaging atherosclerosis in that scenario is the best single risk stratification tool. And in particular, when atherosclerosis is absent, or in the case of coronary artery calcium scoring, when the CAC score is 0, I think it can be very reassuring for short to medium term risk decisions. In my own practice, I couple a CAC score of 0 with a repeat scan in about 4 to 5 years in my practice. But we know that cardiovascular risk is evolving, and in particular, cardiometabolic health is worsening, or what we've called the cardio-kidney metabolic multimorbidity. In this slide, showing data from NHANES, which is a nationally representative sample, the presence of cardiorenal or cardiokidney metabolic multimorbidity is increasingly common and is probably undertreated amongst U.S. adults. This altogether kind of demonstrates a need for enhanced approaches to risk assessment and management that fully capture the contemporary population. Through a variety of proposed mechanisms, the rise of cardiokidney metabolic multimorbidity drives risk in ways that the prior risk approaches or prior risk assessment or equations only partly capture. Therefore, the AHA has endorsed using the PREVENT equation, which is a new risk calculator incorporating the broader view of risk prediction. Indeed, it's built with a base risk calculator that's fairly similar to our prior equation, the pooled cohort equation, which incorporates standard cardiovascular risk factors, including age, sex, blood pressure, cholesterol values, diabetes, smoking, and medication use, but now including the use of lipid-lowering therapies or statins. It also expands the risk factor burden that it accounts for, including kidney function, which was not previously captured by the pooled cohort equation, as well as the presence of diabetes or prediabetes by incorporating hemoglobin A1C and markers of urine protein ratios. So with that framework of approaching risk more holistically in consideration of the cardiokidney metabolic morbidities, I wanted to show how coronary calcium scoring performs among subgroups with these risk factors. And then also at the end, we'll talk about how it performs amongst women compared to men. So let's take a look at the data for each of these categories individually, starting with type 2 diabetes or metabolic syndrome. So in this analysis from MESA, among patients with type 2 diabetes or metabolic syndrome, we can see that incident ASCVD increases across CAC score categories. So here on the left, you have CAC scores of 0, 1 to 99, 100 to 399, and greater than 400. And we have ASCVD event rates per 1,000 person years. This is another way of saying following 100 patients for 10 years. And we do see increasing event rates across these categories. So sort of a stepwise increase across these broad CAC score categories. But also within these categories, as you look at patients without metabolic syndrome or diabetes, you get very low event rates in the CAC score 0 group, little higher as you go to 1 to 100, and higher still as you get to the higher CAC categories. That same pattern holds true for those with metabolic syndrome or with diabetes, but for each of those individual risk factors, we see slightly higher risk. So comparing in the CAC score 0 group, those with metabolic syndrome or with diabetes, we see higher event rates compared to those with neither risk factor. So we do know that these conditions, in this case, diabetes or metabolic syndrome, does contribute to risk, but that the CAC score can still be very telling in this group. And in general, a CAC score of 0 still shows a low risk in this group, and certainly higher CAC scores show much higher risk. From the same study, we generally see that the duration of diabetes, longer than 10 years compared to less than 10 years, doesn't seem to impact the risk that much, except perhaps in those with the highest calcium scores, those above 400. So here in the top line, we see two Kaplan-Meier curve events here showing a similar risk, whether you have have had diabetes less than 10 years or longer than 10 years, if there is no coronary calcium. So a CAC score of 0 is fairly reassuring in the MESA study. The next two lines are nearly superimposable. Those are those with a score between 1 and 399. Whether they had diabetes for more than 10 years or less than 10 years, similar risk, similar event rates. These bottom two lines, you do see a separation. These are amongst those with a CAC score greater than 400. The orange line here is those with diabetes less than 10 years, with this bottom red line being those with diabetes longer than 10 years. And you do see some separation of those curves even early on. But I want to highlight that the numbers for this analysis get really low in those categories. So a less confident assessment of events or differences in event rates in that group of patients. In a separate cohort looking at about 800 patients with diabetes followed for mortality at 15 years, we still see that across calcium score categories, a stepwise increase in mortality risk. That holds true for those without diabetes as well as those with diabetes, seen in the red here. However, I do want to highlight the significantly higher risk, even amongst those with a CAC score of 0 in the diabetic population when followed to a longer, when followed up for a longer time frame. So, the mortality rate of 8.7% over 10 years in those with diabetes and a CAC score of 0 is still a pretty high risk population, certainly. So the take home for me, for those with diabetes, in my practice, if a patient with diabetes does not want to take a statin, I will use imaging and discuss with them the limitation of potential long-term prediction in patients with diabetes. So I tend to repeat scans sooner in this group. And what I'd really love to know is how a coronary CT angiogram may augment this decision or this paradigm. And it may be more additive in this in the calcium score of 0 group with diabetes, but we just don't know that answer yet. Moving on, what about patients with chronic kidney disease? And this is historically a group that I generally think of as having more coronary calcium because of their certain disorders in calcium handling once they develop renal disease. This is a nice study that kind of made me rethink that approach. So this is the chronic renal insufficiency cohort, or CRIC. And in this group, they have shown that there is still a nice heterogeneity of the presence of coronary calcium and the burden of coronary artery calcium across GFR categories. So we see even in those with the lowest GFR, less than 30, more than a third have no coronary calcium. And I'll show you their event rates shortly. And that holds true across this, cohort, that at least a third to even more than a third, depending on the baseline GFR, will have no coronary artery calcium. So we see this heterogeneity, and this is something I want to highlight through the rest of this talk, is that despite risk factor burden, we do see heterogeneity in atherosclerosis burden. And atherosclerosis burden better approximates risk than just risk factors alone. Of course, those with no coronary calcium in this cohort tended to be younger, have a higher prevalence of women compared to men across these increasing calcium score categories. What about risk? So indeed, in those from this cohort, the calcium score of 0 had the lowest risk over time, though it does approach some higher ranges as you get longer follow-up. And then a stepwise increase in risk as you go up to higher categories, with the middle line here being those between a score of 1 to 99, and the top line being those with 100 or higher. So amongst patients with chronic kidney disease, I would say the calcium score performs well across the range of chronic kidney disease. And I think there's room for consideration of a calcium score in this patient population and deferring treatment if the patient is reluctant to start a statin. And of course, in my practice, I do repeat the score in the calcium score 0 population, probably around 4 years or so in this group. An interesting group that really highlights the main value of CAC scoring in my mind, and I think of calcium scoring or atherosclerosis imaging as an integrator of the exposure to all of these risk factors, but particularly amongst those with dyslipidemias, since many of our treatments that we use calcium scoring for really focus on lipid disorders and controlling lipid levels. So here, Seth Martin, when he was a co-fellow of mine, more than 10 years ago now, published this study in Circulation from Mesa, looking across categories of lipid disorders, defined as an LDL above 130, a low HDL cholesterol for their gender, or a high triglyceride level above 150. And you can see in this slide that the distribution of coronary artery calcium is quite heterogeneous, whether there are no lipid disorders, so in this group here on the left, where 20% still have a calcium score greater than 100, or they have multiple lipid disorders, and again, about 20% have a calcium score greater than 100. And about anywhere from 45 to 60%, depending on the number of lipid disorders, will have no coronary artery calcium. And so I think this really highlights how risk factor burden associates with atherosclerosis, and that there's tremendous heterogeneity in that. Indeed, when you look at events, again, those with a calcium score of 0 have low event rates across the range of LDL cholesterols in this example here. And we see a stepwise increase again in risk as you get to higher calcium score categories. So there's high risk if you have a calcium score above 100, even if you already have an LDL less than 70, which creates some dilemmas for treatment. But in my population, I will generally still treat with a statin in this group. And to hammer this point home, this heterogeneity in risk factor and atherosclerosis burden is this study, this nice analysis from the Western Denmark Heart Registry with 5-year follow-up. And the authors analyzed the hazard for events stratified by the presence or absence of baseline CAC. So CAC score of 0 versus any CAC at all. And what they really show is only in those with coronary artery calcium at baseline do we see an association of increasing LDL with increasing risk for atherosclerosis, atherosclerotic disease, here shown as MIs and ASCVD. But in the group with a CAC score of 0, we see quite large numbers here that an increased LDL or higher LDL does not necessarily associate, certainly not statistically significant, and almost null in this group for ASCVD events with those events. So really, to me, says that those who have evidence of atherosclerosis or CAC is the group where an increased LDL starts to really associate with risk. So I'd highlight that in the normal LDL cholesterol group, there's still a very heterogeneous presence of CAC, and CAC does still predict risk in that group strongly. Finally, what about women versus men? Not necessarily cardiometabolic, but I think an interesting group. We see in this analysis from the CAC consortium that across age range from from younger patients to older patients, women have less coronary artery calcium than men. And indeed, it's around the age of 45 in women where we see higher prevalence of CAC or an increased inflection point. And in men, that probably happens at a younger age, 35 or maybe 40. And you'll see that the guidelines highlight this. So it's recommended in men to consider it when they're older than 40, but in women to wait until they're 45, because the yield of the test is lower in younger women. However, when CAC is present in women, it may indicate even higher risk than in men, as seen in the same analysis. So in the CAC 0 group, similar event rates, but in those with any CAC, we see higher event rates in women over time. This was a referred population, the CAC consortium for CAC scoring. And we see in this study from MESA, following them out for a longer follow-up period, which is a population-based cohort, probably more similar predictive ability of CAC in women compared to men. So I think to sum up that part of the talk, CAC starts a little later in women, but predicts risk similarly, at least similarly, or maybe even more strongly, or at least higher risk amongst women compared to men when it's present. So with that, I thank you for your time and attention and look forward to our discussion session. Thank you.
Hi, everyone. Well, that was an awesome start to the program. We're excited to be able now to take a few questions from the audience and to do some discussion with our presenters. Welcome to you all back, and thank you to our speakers for these great presentations. We'll start with the first question to Mike. Mike, is there an optimal age to start doing calcium scoring? Should we be doing it in young people in the 30s? And if it's 0 or if it's positive, does that change how we act?
Yeah, that's a great question. Our new dyslipidemia guidelines started to address that question a little bit. They said in borderline or intermediate risk patients, men above the age of 40 and women of the age of 45 would be a great age to consider a calcium score. But that still doesn't address, I think, the question. The question's asking about, well, What about special cases? What about people with risk factors in their 30s, family history, so-called risk-enhancing factors, elevated lipoprotein A? And absolutely a place for selective use of calcium scoring at younger ages. Usually in my practice, that's men above the age of 35, women above the age of 40, maybe if they have a special risk factor to consider. We'll have to see where the prevention guidelines go about that question beyond where the cholesterol guidelines went. But yeah, I think above the age of 35, strong family history, high lipoprotein A, risk-enhancing factors, women above the age of 40. There's a paper in JACC that covered some of this and gave the number needed to screen, and you can kind of look at that and figure out where you think the sweet spot is. But really, if you're talking about men about the age of 35 with some risk-enhancing factors, really still you only need to scan probably 1 in 5 patients to find elevated calcium. And as you know, any calcium at that age will put you well above the 90th percentile, or at least definitely above the 75th percentile in that treatable zone. So yeah, that's actionable right away.
Thank you very much.
Awesome.
So sorry,
Dr. Joshi.
I'm on call, so I had a patient that I had to deal with.
He's
No
back.
problem. We're glad
Great
you're able to
session so
join
far.
us in the middle
Yes.
of your clinical day. Dr. Joshi, I'm going to ask you the second question. If someone detects incidental calcium, like on a non-gated chest CT, should they still order a gated calcium, or should they still get a calcium score, or is that actionable?
Yeah, it's a really great question, and I think it's been an interest of mine for a while now. And there are guidelines now from the SCCT that came out about 10 years ago that radiologists should report the amount of calcification that they see on a chest CT done for non-cardiac reasons. So for the last 10 years in our system, our radiologists have reported none, mild, moderate, or severe amounts of coronary artery calcium. And it's really just an eyeball test of the radiologist. Our question was to look at this in our system and take patients that had calcium scores within 6 months of their chest CT. And we published this a couple years ago. When they called no calcium, it's pretty common that there's no calcium on a formal calcium score. There are some misses. So you can imagine a patient coming in to the emergency room middle of the night. It's a PE protocol, and the radiologist is just quickly reading through for the emergency question, and they may click through and say no coronary calcium. We did it in contrast scans as well as non-contrast scans, and so you do see some misses when the radiologist reports none. When they report moderate or severe amounts of coronary calcium or a large amount of CAC on a non-gated chest CT, it's almost always a score that's in the hundreds or higher. And so, I think you can be pretty assured that if there's a moderate or large amount on a prior CT scan, that a calcium score is not going to really move the needle very much and would just add radiation and potential for incidental findings in that population. I think it's actionable when it's already a large amount or moderate amount. The mild amount may be where it gets a little trickier. A small amount of coronary calcium, is it really in the coronary arteries? Is it somewhere else? I look at those scans myself just to make sure, that to my eye, it looks like it's there, and it gets a little more nuanced in that group. But we don't generally recommend any downstream testing as the result of this finding. And Khurram mentioned this, but in the Notify-1 study that he presented from the Stanford group, when you notify patients of incidental coronary calcium, you will see some increase in cardiac testing afterwards. So we just have to be thoughtful about that. And it makes sense. If I tell you have something going on under the hood, you may say, hey, that chest pain that I didn't want to mention to my doctor, maybe I need to mention that. And you can see how that can lead to more testing. So we just have to be careful, but a really powerful tool that we can capitalize on.
Thank you so much. For radiologists watching this, so important to grade the severity of the calcification. And last question to Khurram. Someone put this question in the chat. I think it's very important. What's the difference between, the actionable difference between percentile and absolute numbers? Is it the same? And how do we deal with race ethnicities that they're not in the MESA cohort?
Excellent question here. I think so. A lot of the work on the percentiles, at least my understanding, and probably if you look at the guidelines, been influenced by Mike's group and their work. So absolute scores are critical, at least when you're looking at the short intermediate term where you have to make a major decision. So my challenge with percentiles in the older guidelines or prior one was when you focus only on the percentile, then you are going to miss higher risk, especially in men and elderly individuals. For example, if you have a 60 plus 65-year-old male with a calcium score of 105 or 110, they may be not counted as greater than 75th percentile for their age and gender versus a young woman, age 45 with the calcium score of 5 would be considered. So if the targets are just based on the percentile, it may underestimate risk in those with high absolute, and absolute scores always triumphs, especially in the short term. But when you're thinking about younger individuals, the percentile really triumphs, because if you get a calcium score of 15 or 20 or 50 in a young man or 5 or 10 in a young woman, we are not talking about short term, but long term, lifelong risk. And if you look at the guidelines, they've been very specific. If you have a calcium score more than 100, and they put in the language or greater than 75th percentile for your age and gender, your LDL target should be 70 or less. So that means if you're a young individuals with minimal calcification or mild, we should be intensifying their treatment in the same way as we would have done somebody for a calcium more than 100. So I think so that distinction is critically important, especially a lot of us may ignore mild calcification or trying to be intensive or even starting statins. It's very important in young individuals. If you say minimal to mild amount of atherosclerosis, you should do that. Now, I'm not really sure if the race is going to make a huge impact, and we can definitely ask Mike to chime in, but I think so the age and gender works as well, and they're not going to be as different. Of course, when you're using the calculators, it may take race into account too. Mike, any thoughts?
Yeah, I'll just jump in. Yeah, race doesn't, it's nice to be representative. Of course, we want the most representative data as possible, and we're increasing that representation with our publication of percentiles in South Asians, for example. But if you didn't know, and you're the radiologist and you're reading a report and you didn't know the race, it's better to still report a percentile, because it might vary by a couple percent either way, but it's better than saying unknown percentile or something like that, which I've seen in reports before. Yeah, it makes some difference. I think for research studies, we want to be as accurate as possible about those percentiles, but really race is a small factor. And I want just a quick plug in for the age 30 to 45-year-old group, as you heard. Go to www.cactools.com, cac-tools.com. That's the calculator for 30 to 45. We'll have a new calculator over the entire age range with as many races as we can study soon. But in the meantime, if you're a reader of calcium scores out there, try to refrain from saying things like, well, 40-year-old with calcium percentiles can't be calculated, because they can be, but we just need to use a different calculator than the MESA tool.
Excellent. Well, thank everyone for joining us. We're going to go ahead and end this session. So to our people who are watching live, you've got a 5-minute break, and then we'll rejoin back here at 9:08. Thank you all.
Thank you.
Welcome back. Glad you guys are joining us this Saturday morning. So one thing to mention is if you want to watch these sessions recorded, they should be available around May 1st on aspconline.org. But for anyone who pre-registered, you'll get an email when those are available. So we're going to move right into our next session about CCTA plaque quantification beyond stenosis. So we've talked about CAC, now we're moving on to CCTA. This session will feature Leslee Shaw from the Icahn School of Medicine at Mount Sinai discussing quantitative plaque by CCTA, what's ready for prime time. Be followed by Matt Budoff from the David Geffen School of Medicine at UCLA, presented lipid-lowering therapies based on CCTA results. What do clinicians need to know? That'll be followed by Deepak Bhatt, also from the Icahn School of Medicine at Mount Sinai, sharing plaque progression regression as a treatment target, imaging endpoints that matter. And finally, Seamus Welton from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease will be presenting hypertension targets based on cardiac CT, integrating new blood pressure guidelines with subclinical atherosclerosis. Again, thank you. Welcome to you all. And now I'll turn it over to Dr. Shaw.
Great. Thanks to everybody for inviting me to give this brief presentation. As all of you know, there's a recent addition, software addition to utilizing CTA where we can quantify the amount of plaque. And I'm going to say what can we do now with this recent software quantification of plaque. And really, there are two clinical uses at this time for quantitative plaque analysis. One is to guide treatment decisions based on the amount of plaque. And the other one is just to get a better understanding of cardiovascular risk beyond that which you can see in coronary stenosis. And so you should take note of the fact that there is a very, very recent ACC statement, which was published in JACC Imaging. You can see some names on the writing committee that I think all of you are very familiar with. Dr. Chandrasekhar was the chair, Ron Blankstein and myself were vice chairs. And I think the first place to understand is where we are is who should have a quantitative plaque assessment, because you can actually visually see plaque on your own and not necessarily need to quantify it or add that expense to the clinical evaluation. So the first stop is to say, does the patient have visual evidence of plaque on the CTA? And therefore, adding a quantitative plaque assessment may be useful to get a better idea of risk in that patient and perhaps guide preventive therapies, the use of preventive therapies. And so sending a quantitative plaque assessment to somebody that you don't see plaque in is not necessarily, it's not going to help you with plaque assessment. So the first stop is, does the patient have plaque? And you also see in the quantitative plaque analysis, you're going to get measurements in cubic millimeters. And those of you who are not familiar with looking at these measures are going to say, well, what does 40 cubic millimeters mean? The first stop along could be to utilize a paper like this, which was published out of Jonathan Leipzig's group a couple of years ago in JACC Imaging. It gives you by age and sex kind of a percentile ranking of plaque analysis. So this could be very, very helpful as you look to understanding the amount of plaque that you see in your patients, both total plaque as well as calcified and non-calcified plaque volumes. And so now let's think about what can we use the first indication for the use of quantitative plaque, and that's really to help you guide treatment decisions. And so while looking at that, I'd like to share with you some recent papers from our group, which was the DECIDE registry. And this was an interesting study design. So bear with me as I share with you just a few bits of insight into what we did during the DECIDE registry. So these were symptomatic patients. They were referred to CTA. So they're your normal patient undergoing a diagnostic evaluation. And you had, if you were a clinician in this registry, the first 90 days of looking at the CT scan was based solely on your understanding of coronary stenosis and guiding what you could see visually, and not necessarily having any plaque assessment, quantitative plaque assessment. At day 90, we provided the quantitative plaque assessment, so which really allowed us, and this was a research design, so it allowed us to look at early decisions, which were guided largely by stenosis, followed by what would subsequently be guided by quantitative plaque analysis. So we're able to kind of tease out which is which, because obviously, as you know, these can be heavily overlaying. These decisions are overlaying one another. And what we noted in the plaque in the DECIDE registry is the use of how we could guide the preventive treatments based upon a plaque stages. Now, there are a couple of plaque stages out there. This is looking at total plaque volumes. And you can look at this paper, again, another paper which was published at the end of last year, where we looked at total plaque volume from mild at the very top, noting a total plaque volume of 1 to 100 cubic millimeters, and made treatment recommendations based upon this. This is expert consensus. You may have different approaches in your clinical practice, but it's good to get an idea as a guide, not necessarily as something which is based on clinical practice guideline recommendations. And you can see as you go down the stages, you know, from mild, moderate, severe, and extensive, that treatment intensity increases. So you get much more intensive care, higher dose statins, maybe considerations of PCSK9s, aggressive blood pressure lowering, and all the things that you would normally do in higher risk patients. And so this gives you a good idea of how you could actually integrate both the understanding of the total plaque on the patient, but also how to integrate it with clinical preventive treatment changes. And what we saw is that at day 90 and later, that about half of patients had a change in management, and trying to get an idea about how valuable these quantitative plaque assessments are in guiding treatment decisions. And here you can see that there was a whole array of types of treatment changes, mostly having to do with treatment escalation, as I think you could expect. Half the patients had no changes, but additional patients had new labs ordered. A few patients went on to having invasive coronary angiography or stress tests, but most of it had to be with new labs. And those patients that did have treatment changes were also more likely to have demonstrable changes in LDL cholesterol. So this is the paradigm you're looking for. If I see plaque, initiate changes in therapy, get more successful results in terms of reducing cardiovascular risk factors burden and measurements over time. And that was an important consideration. And what we also saw in the DECIDE registry on the left-hand side is that as patients had more and more extensive plaque, looking at the total plaque volume stages, we were more often likely to get much more patients with much more intensive changes in management, as you can see on this first slide, first figure on the left, particularly in those patients with moderate to severe. Roughly 2/3 of the patients had some change in management, which is important given the risk in that population. There was a recent paper from the SCOT-HEART-2 trial, and you say, I don't know SCOT-HEART-2 because this is the first paper from it. It was a sub-study, and what they did was look at if a patient had a CT, and these were asymptomatic individuals, what kind of healthy lifestyle changes did they initiate? Were they more adherent to? What guided preventive therapy decisions? And as you can see on these violin plots, particularly on the one on the far right, is the changes in LDL cholesterol in the patient that didn't have any plaque versus those that had plaque. And those patients that had plaque were more adherent to healthy lifestyles, had better adherence to preventive care, and subsequent much greater reduction in LDL lowering. So both of these studies, I think, add to your abilities to understand that plaque can be used to guide preventive treatments. And of course, this is along the lines with the first SCOT-HEART trial, which noted that patients that was randomized to the CT arm had greater aspirin utilization and higher utilization of statin therapies. And this was attributable to eliciting a reduction in coronary heart disease death or myocardial infarction in the CTA arm. And we're hoping to see additional trials similarly, that once we integrate CT findings with preventive care that we can actually elicit reductions in major adverse cardiovascular outcomes. What else can you do with the quantitative plaque analysis? Well, certainly you want to be able to see, what are the differences in risk between these two populations that once you have that information. And so you want to be able to look at meaningful changes in ASCVD risk. And the first thing you would look at is some information about plaque stages. And the first, there's a number of papers now that look at changes in total plaque volume as a predictor of a major adverse cardiovascular events. That's why we use that change the stages in total plaque volume in the DECIDE registry. Here you see a nice example of this with the survival curve on the right from the ischemia study, looking at changes in stages of plaques from less than or equal to 250 cubic millimeters all the way up to greater than 750 cubic millimeters. And all of this, of course, gives you a nice ability to risk stratify that patient based upon their likelihood of cardiovascular death or myocardial infarction. You may also want to think about plaque vulnerability as a strong predictor of higher risk stratus, in particularly associated with acute coronary syndromes, and that's that lipid-rich or non-calcified plaque volume. Of course, you have to understand that that type of risk may be mitigated by preventive care and the intensity, particularly of statin therapies. And so you may not appreciate that full ability to risk stratify in the treated versus untreated patients. And of course, you should realize there's a timing to risk. And the more plaque you have, the higher the near-term risk of major adverse cardiovascular events. And we have very recent data suggesting that risk in women is higher at a lower plaque burden. And I'm going to go through a couple of these studies in the next few minutes. So looking at another example, looking at the ability to identify risk of acute myocardial infarction, this is data from the first Scott-Hart trial, looking at low attenuation plaque, that darkest of non-calcified plaque volume, showing that low attenuation plaque, a plaque burden of greater than 4% was the strongest independent predictor of incident myocardial infarction, increasing the relative risk roughly twofold. Another piece of information that you could look at is this ability to understand the risk with low attenuation plaque burden. And of course, again, we've seen, just to illustrate another example of looking at plaque risk assessment using plaque quantification. This is again from Scott-Hart, looking at a total plaque volume of greater than 238, roughly speaking, approximating the total plaque volume stages that you've seen on prior slides, showing an elevated risk of cardiovascular death and myocardial infarction by increasing that risk by about 7-fold. So another piece of information reinforcing and validating that prognostic risk with looking at total plaque volume. And again, this is some data looking at quantitation in the PROMISE trial now. This was just published in the last few weeks, looking total plaque volume on the top, total plaque burden, which normalizes to the amount of plaque in a given segments, as well as non-calcified plaque volume. You see this for each of these examples, you see the total plaque volume survival curves and total plaque burden survival curves on the left, as well as non-calcified plaque burden on the left. And then using a cut point analysis, what was the absolute cut point? PROMISE trial, slightly lower risk populations. You're going to see a slightly lower risk threshold. It's somewhere around 90 cubic millimeters of plaque. And you can see total plaque burden. You can see that at a threshold of 35%, and non-calcified plaque at roughly half that of total calcified plaque. So depending on the risk in the population, you might have slightly different thresholds. These types of analysis can be extremely helpful for you to understand, the difference between minimal amounts of quantified plaque versus more robust measures and higher risk measures of calcified plaque, coronary plaque. Here's some data which was interesting, was published last year from the CONFIRM-2 registry. About half of the 3,500 patients were women, and at every stage, whether it be total plaque volume, non-calcified plaque volume, and calcified plaque volume, the hazard ratios for major adverse cardiovascular events were higher in women than they were in men. Obviously, plaque on a woman's arteries, which is lower, is encumbering a larger proportion of the total plaque, the burden of plaque in a given epicardial arteries. And this actually supports the idea that we may need sex-specific thresholds. So looking at this report could be very helpful for you to understand what is the plaque, in that a lower plaque volume may actually be associated with higher risk in a female patient population. And this is a paper that was, again, published just in the last few weeks, looking at risk in women and noting that the risk actually increases at a substantially lower plaque burden than in men. Another paper from the PROMISE trial. And you can see by looking at the hazard ratios in the figure on the right that the risk in women, which is this orange line, emerges at a substantially lower plaque burden, somewhere at around 20% plaque burden. That means 20% of the total vessel volume is encumbered with plaque, as opposed to substantially higher, somewhere at around 30% in men. So understanding that these smaller arteries with any kind of a plaque burden may have a higher risk in women is an emerging concept that now we've seen supported in a couple of recent papers from PROMISE as well as from CONFIRM too. And so I think in summary, what can you do if you have an interest in using plaque to integrate it within your treatment strategies? I think this is absolutely an emerging and pathway. We don't have any randomized trials to help with this, but certainly I think this is something, there are expert opinion pathways, which there are several which have been published, which may be helpful to you. You may want to tweak it. Obviously, these are guidance documents based upon your individual patient. And therefore, I think you're getting closer by using these pathways to really getting more precision guided care for your patient. And certainly you can get some insight in how quantitative plaque estimates can give you an insight into near-term major adverse cardiovascular risk. I hope this is helpful for guiding you using quantitative plaque analysis, and I look forward to ongoing discussions and the development of new evidence in these areas. Thanks for joining.
Well, thank you very much. I'm Matthew Budoff, a professor of medicine at the UCLA School of Medicine and director of preventive cardiology. I'm going to be talking to you today about lipid-lowering therapies based upon CTA results and what clinicians need to know. These are my conflicts of interest. So, as we've been able to get more and more information out of cardiac CT, the amount of information, the validity of the information, the reproducibility of the information has really allowed us to track atherosclerosis over time, both in a population and in an individual. And I think that that's allowed us to first use this for clinical trials and now use this in clinical practice. So non-invasive imaging of atherosclerosis allows for serial imaging of changes in coronary atherosclerosis. It's less expensive and minimally invasive compared to the old ways of doing this, which was intravascular ultrasound or OCT, modalities that are largely now obviated by the excellent image quality that we have with cardiac CT. And the advantage of cardiac CT is we don't see just a segment or two segments, we see the entire coronary tree. So it allows imaging of both the culprit and non-culprit vessels, and we can really get a complete picture of plaque volumes as well as associated changes. The primary endpoints of most of these, the primary analysis when we're talking about using plaque volumes to guide treatment, is non-calcified plaque volume. But that's broken down into both a low attenuation or lipid-rich plaque, what some would call the necrotic core, and high attenuation, which is fibrous and fibrofatty plaque, which is likely more stable, but still part of our non-calcified plaque volumes that constitute how much plaque is in a coronary tree. And then, of course, separate from all of that is calcified plaque, which we think of as very stable and kind of more like scar tissue after the evolution of these other plaques. CT angiography has gone excellent evolution. an excellent correlation with intravascular ultrasound. We have outcome data showing plaque predicts events, and it's now the most accurate and fastest growing non-invasive modality for the diagnosis of coronary disease. In the 2021 chest pain guidelines was the only imaging modality to get a class 1A recommendation for use. So we have this pictures now that we used to just look at and say, oh, I think there's a 30 to 50% stenosis in that proximal circumflex. I think there's a mild stenosis in the LAD, and I see some non-calcified plaque in that middle panel where there's two white arrows, and I see some calcified plaque where there's a single arrow above it. Now we can get lumen volumes and plaque volumes and millimeters cubed of non-calcified plaque, calcified plaque, low attenuation plaque. So really get a lot of information for the individual and to follow them over time. The basis of these new plaque softwares that are available now, this is one of them, looks at the ability to really differentiate patients based on how much plaque is present. Whether we look at plaque atheroma volume, percent atheroma volume that's often used in IVUS and other invasive techniques, or whether we look at total plaque volume. You can see if they have no plaque in orange, just like if they have no coronary calcium, the prognosis is excellent and the event-free survival over 10 years is perfect. If they have a little bit of plaque in green, they have more events over 10 years. If they have a moderate amount of plaque in dark blue, they have about twice as many events, and their event rates double yet again. Yet again, they double if they have severe plaque volume, or what we would call stage 3 plaque. It adds not only to clinical risk factors, it adds to coronary calcium scores to improve 10-year risk stratification, and the net reclassification index goes up, and the area under the curve for accurate diagnosis goes up. Another study called Fish and Chips. Fish and Chips looked at plaque staging with about 2,800 patients appropriately done in the United Kingdom, and you can see similar data. If you have a gray line at the top, it has 0 plaque volume, and they have good outcomes. And if they have trivial, or what they call mild plaque, what I call trivial plaque, 1 to 100 millimeters cubed, not calcium score, but millimeters cubed of total plaque, they have really pretty much the same risk. But once they get over 100 millimeters cubed, their risk almost triples. It goes up to almost 4-fold if they have plaque above 250 millimeters cubed, what they call severe plaque. And if they have extensive plaque above 750 millimeters cubed, their risk is almost 5-fold higher for having a cardiovascular event. This is on top of now risk factors, stenosis severity, and FFRCT, or flow down the individual vessel. But I think the most important data comes from this manuscript. This paper was done by Dr. Motoyama in JACC. The plaque progression at the bottom shows a 33.4 fold increase hazard ratio. So we have a 33.4 fold increase risk in this paper, showing that if plaque progresses over time, it is the best predictor of future cardiovascular events. Better than age, better than dyslipidemia, better than prior smoking, better than even having high-risk plaque at either the first or second CT angio. Plaque progression portends future events. Very, very important information. Here we can see the concept of following patients over time. This was one of the early studies done looking at plaque progression, and you can see patients on drug X or drug Y having less plaque progression than placebo. This is a 6-month study. Most of the trials now are done 12 to 24 months in length. We started with statins. This was a trial that I was involved with early on. Now 12 years ago, published looking at plaque and serial changes, and you can see that if patients were on a statin instead of placebo, they had regression of total plaque volume. They had regression of non-calcified plaque volume. They had regression of low attenuation plaque, or that vulnerable plaque, and they had slowing of progression of coronary artery calcification, or coronary plaque, calcified plaque volume. Another study done looking at atorvastatin versus placebo in an HIV population, showing that if you put patients on atorvastatin, you have slowing of atherosclerosis as compared to placebo. And the Reprieve study showing us that large trial now, 800 patients initially randomized, over 750 followed up over 2 years, showing that if they're on a statin, in this case pitavastatin, they had plaque regression of non-calcified plaque volume and plaque regression as compared to for low attenuation plaque volume. And both of those were statistically significant compared to the placebo arm, which had progression of non-calcified plaque volume over those same 2 years. So it showed not only a decrease in non-calcified plaque volume, but a 33% lower risk of developing plaque progression if you're on pitavastatin as compared to placebo. We all know statins work and statins lower events. And in that same Reprieve trial, pitavastatin lowered cardiovascular events. So the pitavastatin in this trial slowed plaque progression and decreased cardiovascular events. So, and this is just a sample image at placebo at the upper left. At entry, they had a little bit of plaque in the right coronary. On the right, 2 years later, they had more plaque, and this shows a pitavastatin patient with a moderate amount of non-calcified plaque that largely went lower over 2 years. But we've had a lot of other therapies that we've looked at. There's been a lot of research looking at fish oils, especially EPA and DHA. There's been a number of clinical trials in imaging. This one was done in Japan by Nagahana, looking at EPA and plaque progression in dark blue. And you can see very little plaque progression. You can see EPA plus DHA with moderate plaque progression. And if you had neither on board, a control population, they don't use placebo in Japan, but if they had no therapy, their plaque progression rates were 35%. So the benefit blunted by DHA and the biggest benefit for slowing plaque progression is based on EPA, and they attributed it to higher EPA levels achieved with the pure EPA. That was followed up with a number of trials. This one was done by my lab where I published the Evaporate trial. And you can see EPA in blue, which is really EPA plus statin because everybody was on statin background therapy, largely had regression of all of their different plaque volumes, low attenuation plaque, fibrofatty plaque, fibrous plaque, calcified plaque did not change, but regression in non-calcified plaque and total plaque volumes as compared to slight progression with placebo, which was statin monotherapy, which is seen in every single trial. If you don't get LDLs low enough, you see progression. The average LDL in this trial was about 85 milligrams per deciliter. It was a trial focused on triglycerides, not LDL, and we see slight progression. So very concordant with all published literature showing incremental benefit with icosapent ethyl. We did additional analyses and showed that icosapent ethyl, this EPA derivative, decreases lipid-rich necrotic core, reduced intraplaque hemorrhage, and increased fibrous cap thickness, all indicating a migration of atherosclerotic plaque to a more stable phenotype. There have been a couple other trials looking at combinations of EPA-DHA with cardiac CT. This is a trial called HEARTS, which showed absolutely no benefit using combination therapy. Again, the thought is that DHA blunts the benefits of EPA on the coronary arteries, and that was reiterated in yet another trial called Aquamarine, looking at EPA plus DHA, both low dose and high dose fish oil supplementation, showing absolutely no benefits on cardiac CT. So when we think about atherosclerosis imaging and at least the omega-3s, we have great, elegant marriages of clinical trial results. The JELIS trial, the REDUCE-IT trial, RESPECT EPA, showing that icosapent ethyl improves outcomes. And now these imaging studies compared to placebo, icosapent ethyl stabilized plaque and reduced non-calcified plaque volume. And conversely, EPA plus DHA, no positive effects on outcomes, 2 large outcome studies, STRENGTH and OMAMI, or on atherosclerosis, as I showed you. Let's move on to the PCSK9s. This is the work out of Dan Berman's lab called EVOLVE. The EVOLVE trial looked at the effect of evolocumab on plaque volume, and you can see a reduction in low density non-calcified plaque, or what we call low attenuation plaque, and a reduction in non-calcified plaque with some progression of calcified plaque in that trial. We published this data yesterday. This was presented at American College of Cardiology, just hot off the presses. And you can see if we use olezarsen, an ApoC3 inhibitor to lower triglycerides in patients with moderate hypertriglyceridemia, we get no significant changes in absolute change in non-calcified plaque and no significant change in low attenuation plaque, although the directionality is correct. So fairly large trial, over 500 patients originally enrolled, almost 500 patients followed up, and you can see really no significant move with ApoC3 inhibition in this population. So we can track plaque over time. We can stabilize plaque. This is a nice example of somebody whose total plaque stayed the same, but their non-calcified plaque volume went down by 59%, and it was replaced by calcified plaque volume. And this was a male taking a statin. So just simple intervention sometimes. We can track. My patient had a little bit of plaque, not on therapy yet, family history of heart disease. I put him on a statin. He had more plaque at follow-up. So I added a PCSK9, and I started seeing plaque regression. So very, very important to see the benefits of non-calcified, of personalizing medicine. So let me sum up and finish up here by saying that changes in atherosclerosis are highly correlated with outcomes. CT angio can be used as a non-invasive imaging modality with low cost and low risk. Plaque progression on serial CCTA can inform clinician and patients that current therapies are not sufficient. We have a lot of additional therapies that can be added, and we can track atherosclerosis in the individual and really personalize medicine by seeing if that person is responding to our therapies. And if they're not, and atherosclerosis is progressing, we can intensify treatment. There's a large number of ongoing studies are underway with cardiac CT, including inclisiran, Lp(a), anti-inflammatories, colchicine, CETP inhibition, as well as combination therapies based on plaque burden to see if we can improve outcomes. So you'll see a lot of information over the next few years. And with that, I will thank you and finish up my talk and look forward to the discussion.
Hello, I'm Dr. Deepak Bhatt, the director of the Mount Sinai Fuster Heart Hospital and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai. It's really a pleasure to be able to speak to you about a few thoughts on plaque progression and regression as a treatment target, imaging endpoints that matter. These are my disclosures, and relevant to this talk is research funding from Amarin and Clearly, as I will be discussing trials that they've funded. A lot of what we do in cardiology, at least, centers around MI, myocardial infarction, heart attacks, either the treatment of them or sometimes the prevention. Now, as far as the treatment goes, there have been a lot of advances, largely based in percutaneous coronary intervention. That's a terrific way of addressing the immediate risk of someone that comes in with a non-fatal myocardial infarction. We've learned a lot about the biology in terms of what causes the majority of myocardial infarctions, plaque rupture, plaque erosion, some other causes that are less common, like calcified nodules. But a real challenge beyond treating MIs, and there's still progress to be made there for sure, is actually preventing MIs, the primary prevention of MI. And these are some recent data, 4.5 million patients from the United States with a first myocardial infarction. And it turns out about 1 in 5 didn't have any identified risk factors. About half had no prior identified symptoms. Approximately 1 in 5 didn't have any prior physician visits, and a large majority wasn't on any sort of preventive therapy, about 2/3. But the biggest challenge here in the context of this talk is that half the patients don't have any documented prior symptoms. So if our approach is going to be to wait until a patient has symptoms such as angina, well, we're going to miss half the patients. And of course, some of those patients that have a myocardial infarction ultimately will be an out-of-hospital sudden cardiac death. So even though there are a lot of advances in treating MI, if the patient never makes it into the hospital, they won't benefit from those. So this is a real dilemma. And it's really why to prevent the first myocardial infarction, we have to move from reacting to myocardial infarction to actually acting. How can we do this? Well, I think in the future, maybe in the present, but certainly in the future, a combination of different approaches to risk stratification to identify who's at highest risk will be necessary. Genetics, of course, that's a hot topic and can be very useful perhaps in determining cardiovascular risk in the future. Biomarkers, in particular panels of biomarkers, can be useful for risk stratification. But perhaps what's closest to prime time to identify patients who might be at high risk of a heart attack is imaging. And there's lots of different forms of imaging out there. Coronary calcium scoring is popular these days in the primary prevention setting. Ultrasound, plaque imaging can be useful with studies going on looking at 3D ultrasound of the carotids, for example, or the femorals to assess plaque burden and potentially track plaque progression or regression. So lots of different approaches are out there, and potentially coronary CT angiography, which is also being investigated in this context. And what I think the future will be isn't so much an either or, but a menu that includes all of these, where to most precisely risk stratify patients, all these different modalities, the biochemical, imaging, genetic, will be utilized to more precisely stratify risk than we're able to now. Here's some data. This was presented in American Journal of Preventive Cardiology recently, but reproduces some data from a prior publication from MESA looking at the coronary artery calcium score and risk of coronary heart disease, and the risk goes up with higher coronary artery calcium score, as is known. There isn't a 0% of event rates in the zero coronary artery calcium, so that's always important to realize, particularly an issue with younger folks. But here is now superimposed a polygenic risk score going from low to medium to high, a high being the dark gray bar. And as you can see, even with the coronary artery calcium score of 0, if the genetics are bad, the risk goes up of coronary events. But the combination, especially with high coronary artery calcium score, there's still some incremental risk afforded by the genetics. So that's why I said it may not be an either or strategy of just one thing, biomarkers or genetics or imaging, but maybe all of these can help more precisely define what an individual patient's risk is. All these things work great at a population level for papers and that sort of thing. The real question is, for an individual patient, how can you really say, hey, this is your future risk of heart attack, stroke, death from these causes? So if coronary artery calcium is good, maybe actually looking at plaque is going to be even better. Perhaps actually staging plaque the way that a cancer doctor stages cancer would be useful. In this particular paradigm, looking at coronary CT angio-derived plaque burden and 10-year risk of cardiovascular events, you can see green is pretty low, stage 0, but then going from yellow to orange to red, stage 1 to 2 to 3, the risk of cardiovascular events goes up quite substantially. So certainly imaging plaque does help gauge the risk of the patient. Now, a question then is exactly what should that imaging do? And some things are clear. So for chest pain, obviously coronary CT angiography is in the guidelines now. I was fortunate to be part of those guidelines where that was given, I would say, a really ringing endorsement. But what I'm talking about, though, is more primary prevention. So in that context, what is important? Is it more functional characteristics like ischemia, more anatomical characteristics like plaque, or maybe a bit of both? So this is one example of an artificial intelligence-enabled evaluation of the coronary arteries using CT angio, longitudinal and cross-sectional representations of a coronary artery that is able then to give us information about stenosis, but also ischemia, atherosclerotic burden, plaque morphology. Is it lipid-rich, quote unquote vulnerable plaque. Other characteristics associated with high-risk plaque, lesion location, lesion length, whether it's concentric or eccentric, potentially then additional values about the diffuseness of disease, remodeling. So lots of information here, really in an individual patient, millions of potential pixels and data points. And if one couples that with machine learning approaches and perhaps even throws in other information like biomarkers and genetics, we can really precisely determine, hey, this patient has X% of having a heart attack. So that would be pretty incredible. It'd be more incredible if we could do that and then figure out what specifically to do, really precision tailored medicine. Getting back to people with chest pain, though, there in the context of evaluation of stable chest pain as shown here, coronary CT angio really does seem to have some advantages over just functional stress testing. And if you look at, as shown in this slide, meta-analyses, randomized clinical trials, or registry data, there does seem to be an associated lower rate of myocardial infarction, probably driven by higher use of preventive therapies. So that does seem to be an advantage of having visualization by the doctor, maybe by the patient, that there's plaque in the coronary arteries. Perhaps it does make doctors more likely to prescribe appropriate evidence-based preventive therapies. Perhaps makes it more likely that patients actually adhere to those therapies. So awesome advantages. But that's interesting. It's theoretical. What about actually testing it? Well, there are trials that are going on. This is one example, SCART-HEART 2, 6,000 patients randomized to standard of care and getting a risk score, the assigned risk score. And based on their risk score in that control arm, if it's a low risk score, less than 10%, lifestyle advice. If it's a high risk score, greater than 10%, additional lipid lowering therapy. And in the investigational arm, the CT coronary angiography arm, it depends on whether there's essentially normal CT angio, non-obstructive or obstructive disease, and the therapy is somewhat titrated based on that lipid lowering and antiplatelet therapies for non-obstructive disease, and then additionally a potential ACE inhibitor and review by a cardiologist for obstructive disease. So interesting trial, good number of patients. Primary outcomes are ischemic events, but a lot of secondary outcomes such as resource utilization, revascularization, safety, quality of life, etc. So really important, interesting study. I think, though, if we could go even beyond that to really tailor the therapies based on what we see on the angio, that would be a step forward. We know that patients should be treated with guideline-based therapy. So in the preventive world, primary prevention, as I'll call it there, oftentimes lipid lowering is indicated, blood pressure lowering in accordance with current guideline targets. But we know that patients still have cardiovascular events when we do that. So what can we do to redefine residual risk and go after residual cholesterol risk or residual inflammatory risk, residual thrombotic risk, residual triglyceride-rich lipoprotein-associated risk, residual Lp(a) risk, or residual diabetes/overweight/obesity risk. Well, beyond lifestyle modification, which is important in the bedrock of all of this, there's a lot of different pharmacotherapies, accepted pharmacotherapies, approved pharmacotherapies, investigational pharmacotherapies. So the choices are driving targets, such as for LDL, even lower than current guidelines suggest, and or targeting novel risk factors like residual inflammatory risk is assessed by elevated high sensitivity C-reactive protein, or Lp(a) related risk, and trials are ongoing. So if we can use the information from imaging to then tailor an individual patient's therapy to address this residual risk, that could really drive down cardiovascular event rates. So let me share now some data that support that paradigm. These are clinical trial results from the REDUCE-IT trial showing a significant reduction in ischemic events with a particular drug, icosapent-ethyl, a highly purified ethyl ester of EPA or icosapentanoic acid. FDA approved, approved by multiple regulatory agencies around the world in the guidelines, specifically for patients at elevated cardiovascular risk with elevated triglycerides, because that was the population we studied, a hybrid primary secondary prevention population. So clear-cut reduction in ischemic events with the therapy versus placebo. So that's an outcome trial. But what about imaging? Could imaging have predicted that? As things turned out, REDUCE-IT was published before EVAPORATE, but in theory, one could have reversed the sequence and used imaging, in this case, non-invasive CT angiography, to see if a particular drug affected plaque. And maybe then, for an investigational agent, it would be reasonable to proceed into phase 3 trials if that initial phase 2 testing looking at plaque progression or regression was positive. Perhaps some might say that would be sufficient if it is a drug with an established track record of safety, maybe sufficient for approval just for plaque regression or preventing progression. So all interesting concepts, all worthy of discussion, all things I'm sure we'll be discussing at the symposium. But at any rate, the EVAPORATE data showing a significant reduction in various constituents of plaque, such as low attenuation plaque and non-calcified plaque versus placebo. You can see in blue the effects of icosapent ethyl versus what happens in these high-risk patients in red with placebo. Significant differences. Now, some have said, oh, but why is plaque progressing in the placebo arm? Well, these are really high-risk patients. These are patients that have cardiovascular risk, and despite being adherent to a statin and a documented LDL in a good range, still have elevated triglycerides. So these, in fact, while outpatients, are high risk. And corroborating that point is look at the event rates in the drug arm and the placebo arm. Both are pretty high, even though the drug was highly effective. The absolute event rates are still extremely high in this population. So there is a lot of residual risk here. So to me, it's not surprising, just as there's residual risk and events that are occurring, including on therapy, that plaque is also progressing in the placebo arm, but reduced with icosapent ethyl. So that's EVAPORATE. And, you know, sometimes a picture is worth 1,000 words. Here we see the effect of icosapent ethyl on progression of atherosclerosis. Again, these are images from the EVAPORATE trial. So real benefits, it seems, in terms of reducing plaque progression with this particular drug, perhaps even changing the composition of plaque in a favorable way. This is EVAPORATE FFR, looking at CT angio, but now using FFR to look for ischemia, showing a significant difference, modest in magnitude, but just over 18 months, a significant difference in favor of icosapent ethyl versus placebo. So the first time in a randomized trial, albeit modest-sized sample size, that any drug has shown an effect on CT-derived FFR. So I think once more, this can be a paradigm for future drug discovery, evaluating a drug in a smaller phase 2 imaging trial using FFR as derived by CT angiography, and potentially, this would need to be validated, titrating therapies in an individual patient based on information like this. So once more, large amounts of randomized trial data would be necessary to endorse that type of concept. This is just a pooled analysis looking at a bunch of not just coronary CT angio trials of omega-3 fatty acids, EPA and EPA-DHA combo therapies. Also looking at IVUS OCT as well. And you can see then when one looks at this, if I can just show you on the next slide, significant benefits noted here of EPA in terms of plaque volume effects, and no effect seen of the EPA plus DHA preparations that had been studied up until this point in time. Of course, the more recent Pisces outcome trial of that particular formulation of EPA DHA did show significant benefit. At any rate, great data then, I think, showing from the icosapent ethyl experience, reductions in plaque progression on coronary CT angio, older trials also showing that on IVUS and OCT-based imaging, and then an outcome trial showing a benefit. So a linkage there between benefits on imaging and benefits on clinical outcomes. But can we go even beyond that and use imaging from CT angiography to guide patient care. Well, Transform is setting out to do that, randomizing 7,500 patients, and we're well underway in that journey, who have metabolic syndrome or prediabetes or diabetes without known symptomatic CVD, so I'll call it a primary prevention type patient, randomized to risk factor control based on the guidelines, or CT angiography-based care, or CAD stage-based care. In both cases, a CT angio is performed at baseline and again at 2 years. It is blinded in the control arm. It is not blinded in the investigational arm, the CT stage-based care. And based on the stage of plaque in the investigational arm, the medical therapy is titrated using FDA-approved drugs, but in ways that go beyond the labeling and beyond the evidence. So drugs we know are safe, but driving LDL levels beyond what the guidelines would recommend, using icosapent ethyl, but in patients that don't have elevated triglycerides, using SGLT1/2 inhibitors, including in patients that don't have diabetes. So basically drugs that are approved, but not in the way that we're using them. So safe, but not necessarily proven in the very intensive medical approach that we're taking based on staging of plaque. So that's the overall trial. And there are 3 parts to it. One is Transform Predict, to see if CT angiography is better than any number of those risk scores that are out there, which are good, but not great on an individual patient level. Can we do better? So that's Transform Predict. Then there's Transform Plaque, to see between baseline and 2 years, that CT angio. In the investigational arm, by throwing the kitchen sink at patients, medically speaking, do we do better than just following the guidelines? And furthermore, if there is plaque progression that we see there in the patients, we will further ratchet up their medical therapy in the investigational arm to see if it makes any difference in the final part of the trial. Transform Outcomes, to see if this strategy actually reduces cardiovascular event rates. That's the aspirational goal of the trial. Beyond the specific strategy we're studying in both arms, the control investigational arm, it'll give us a great opportunity to see how plaque progression, plaque regression are linked to cardiovascular outcomes. So it's an ambitious trial, lots of different parts to it, but so far the trial seems to be going pretty well. And ultimately our goal then in Transform and related trials is to elevate heart attack prevention to the level of cancer care. That is, much like mammography, colonoscopy, lung CT scanning is indicated for evaluation of breast cancer, colon cancer, and lung cancer, respectively. Randomized clinical trial data supports such screening in appropriate populations. Guidelines endorse it. Insurers cover it. The hope is, if the trial is positive, to transform cardiovascular care in the same way, so that we can screen for coronary artery disease in a way that actually improves patient outcomes. Well, thank you very much for your attention. Hopefully this was interesting and helps link together some of the existent data and data yet to come regarding plaque progression and regression as seen on CT angiography with cardiovascular events. Thank you.
All right, well, thank you very much for the opportunity to speak today. And today I'm going to be discussing how we can use cardiac CT to integrate our treatment and risk evaluation of patients with hypertension based on the 2025 ACC/AHA hypertension guidelines. So I think it's important to mention that hypertension is the most common modifiable cardiovascular risk factor, and in large part because of its very high prevalence, hypertension actually is the risk factor with the largest contribution to CVD mortality worldwide. Despite that, we know that hypertension treatment and control actually remains pretty low, even in the United States. Here, this is data from NHANES 2021 to 2023. We can see that only about 1 out of 5 patients in the United States has adequate blood pressure control. And so what that tells us is that we really need better approaches to identify those patients who are most likely to benefit from treatment and treatment to very low blood pressure numbers. So I just want to mention here, we're going to be talking about patients with hypertension, but we know, like most risk factors, that there is a continuum of risk. And this is data from the MESA study. And this is looking at patients who have otherwise normal risk factors. And we can see that even in these normal blood pressure range, that there's a significant association between systolic blood pressure and the risk for subclinical atherosclerosis, here defined as coronary artery calcium. And we also know that in general, for most patients, they don't have one single isolated risk factor. We see here that this is data looking at patients who have progressively higher risk factor burden, with the lower on the right and higher on the lower on the left and higher on the right. And what we see is that within the systolic blood pressure groups, with the lowest group of 110 being in orange and the highest group of 170 being in the blue, that within each of these risk factor clusters, a higher systolic blood pressure is associated with a higher 10-year risk for total CVD. And this is an important concept because we know that higher absolute risk for cardiovascular disease, those are the patients that are most likely to benefit from treatment of CVD risk factors. This is data from the Lancet from 2002. And we know that older patients are at higher absolute risk for CVD. And what I just want to point out here is that if we look at the absolute risk within differences or delta in systolic blood pressure, we can see that the absolute risk is highest for those patients who are with the higher systolic blood pressures, who are older and at higher absolute risk compared to patients who are younger and lower absolute risk for cardiovascular disease. And that's important because the guidelines recommend or acknowledge that a CVD risk-based approach is superior to a systolic blood pressure treatment alone-based approach. And there's a couple of reasons for that. One reason being that we know that if we focus on patients at highest absolute risk, those are the patients that we're going to have improved efficacy and improved efficiency of treatment. That's going to lead to a lower number needed to treat. And we also know that if we're focusing on higher risk patients, because of the improved efficacy and efficiency, that it's going to be a lower cost per patient to prevent one cardiovascular disease event. So what do the 2025 hypertension guidelines recommend? Well, they recommend for patients who have a systolic blood pressure of 130 to 139, that's really going to be the group that we're focusing the most on from a risk-based approach. For those patients in that blood pressure range who already have cardiovascular disease, the guidelines recommend that those are high-risk patients who should be treated. But for patients without cardiovascular disease, they recommend that you should consider treating those patients if they have diabetes, chronic kidney disease, or importantly, with regards to this talk, a prevent CVD score of greater than or equal to 7.5%. And I also want to mention here that they have a separate recommendation here for the treatment goal, that for patients who are classified as high risk, and they classify that as patients again with a prevent score of greater than 7.5%, that there's encouragement for those patients to achieve a systolic blood pressure goal of less than 120 millimeters of mercury. So where did they come up with these numbers? Well, this is data from the SPRINT trial, which is the first large trial to show a benefit to treatment to less than 120, but since then we've had a number of other trials showing similar benefits. And in the SPRINT trial, one of the inclusion criteria was a Framingham risk score of greater than or equal to 7.5%. And about 3/4 of patients in the SPRINT trial had this Framingham risk score. And what we know is that a Framingham risk score of 15% is equivalent to about a 7.5% prevent cardiovascular disease risk score. And the authors actually in the hypertension guidelines directly reference cardiac CT, and they mention that this 7.5 prevent CVD score, that's equivalent to about a 75th percentile CVD risk among untreated patients who have a systolic blood pressure of 130 to 139. And they mentioned that, this is a similar idea of the 75th percentile for coronary artery calcium scoring in terms of the dyslipidemia and prevention guidelines. So how do we relate this directly to cardiac CT? Well, we know that in this study from the CONFIRM trial that Budoff published, that a coronary artery calcium score of greater than or equal to 300, those patients have a CVD risk equivalent to someone who has a prior ASCVD event. We see that patients with a CAC score of 300 in the purple overlap that line of patients with a prior ASCVD event in the yellow line. And I also want to mention that in the SPRINT trial, one of the inclusion criteria was having a coronary calcium score of 400 or higher. So those are important numbers to think about when we're thinking about which patients we should treat and maybe which patients we should treat to that lower blood pressure goal of 120. This is a paper from the MESA study by Bill McAvoy, and this used a SPRINT eligible participant population. And what he showed here was that if we look at this SPRINT population and we apply coronary artery calcium scoring, we can see that can really nicely stratify the lower from the higher risk patients. And the patients who have a coronary calcium score of 0 being in the blue group have a relatively low risk of CVD and heart failure over 10-year follow-up, while the patients who have a coronary calcium score of 100 or higher, we can see have a much higher event rate for CVD and heart failure over that same 10-year follow-up time. So how do we relate the PREVENT score and coronary calcium scoring together? Well, we know that in general, patients who have a higher CVD risk factor profile are more likely to have the presence of subclinical atherosclerosis. And not surprisingly, we see here that with higher PREVENT scores, there's a lower prevalence of coronary artery calcium score 0. That being said, there's actually pretty significant discordance between the PREVENT score and the presence of atherosclerosis. We see that in the intermediate risk group, about 35 to 40% of those patients have a positive coronary artery calcium score. And in the patients who have a PREVENT score of greater than 7.5%, about 25 to 30% of those have a coronary calcium score of greater than 300. And one thing I just want to point out here in this graph, this using the pooled cohort equation risk cutoffs, because this paper was published in 2025 before we had the most recent 2026 dyslipidemia guidelines. But the PREVENT ASCVD equivalent risk scores are going to be lower compared to the pooled cohort equation score. So just to keep that in mind when we're looking at this graph. That being said, while coronary artery calcium score certainly improves ASCVD risk stratification beyond the PREVENT score, if we use the PREVENT score and the coronary calcium score together, that can really help to further refine and personalize our risk estimates. We see here in the green patients who have a coronary artery calcium score of 0 and a PREVENT score of less than 5. They have the lowest risk of ASCVD in the bottom left corner. Comparatively, if we look at patients who have a coronary calcium score above 300 and a PREVENT score of greater than 15%, in that top right corner in the red, you see they have the highest risk group. One point I just want to make here is that if we look at those patients or participants with a calcium score of 0, but a PREVENT score of greater than 15%, we can see that they might have a little bit higher risk than we might predict or expect for a coronary calcium score 0. But if we think about the prevalence or the percentage of patients in that group, it's going to be a pretty small number of patients who fit into a coronary calcium score of 0, but have a very high risk factor burden. So what about using coronary calcium score to refine treatment and risk estimation for these patients, consideration to treating to a systolic blood pressure of less than 120? We know that coronary calcium scoring can be helpful here as well. Again, this is a paper from Bill McAvoy using the MESA database. And what we see here is that the top of it is looking at patients with lower risk compared to patients with a higher risk in the bottom. But again, the main point I want to make here is if we look at the coronary artery calcium score, we see that that really helps to refine the risk estimate and the number needed to treat. Patients who have a coronary calcium score of 0 have a much higher, almost 3 times higher number needed to treat to prevent one ASCVD event over 10-year follow-up compared to patients who have a coronary calcium score of greater than 100. This is another paper from the Coronary Artery Calcium Score Consortium, and what they wanted to do here was really further refine our use of coronary calcium and cardiac CT and help us figure out what is the coronary calcium score that equates to the risk that we observe in the SPRINT trial. So what they did here was they looked at the CVD mortality rate from SPRINT and they applied that to the Coronary Artery Calcium Consortium. And they found that a coronary artery calcium score of about 220 equated to that same SPRINT CVD mortality risk population. Using about a 15% difference in risk estimates between the SPRINT trial and the Coronary Artery Calcium Consortium, we can see that that would give us a confidence range of somewhere between 165 and 270 for the coronary calcium score. And so lastly, what I want to mention, we most commonly use coronary artery calcium scoring for atherosclerotic cardiovascular disease, but we know that coronary artery calcium is associated with many other types of CVD, and we also know that systolic blood pressure is a very strong risk factor for other types of CVD. In the SPRINT trial, one of the main drivers for the reduction in risk that was observed was the reduction in heart failure, and there's about a 37% reduction in the risk for heart failure in patients in the SPRINT trial who were treated to a systolic blood pressure of less than 120. And so again, this is data looking at blood pressure ranges in coronary artery calcium. And what I want to point out here on this lower table is if we look on the far right graph, those are patients who have an elevated or low risk hypertension stage 1. And we see that the number needed to treat there is much lower than patients in that same blood pressure range who have a coronary artery calcium score of 0. So again, through using coronary artery calcium scoring, we can really refine risk estimation, and we can better identify those patients who would benefit from treatment of blood pressure and also treatment to very low blood pressure goals. So again, we know that control of hypertension is very low in the United States and worldwide, and we need better approaches to improve blood pressure control. We know that in high-risk patients, treatment to a systolic blood pressure of less than 120 is associated with about a 25% lowering in the risk for cardiovascular disease. We know that the PREVENT score is a good place to start, but by using coronary artery calcium scoring, we can further refine, personalize, and individualize cardiovascular disease risk, and using that, better allocate medications and better define which patients should be treated for blood pressure to less than 130 and which patients we should treat to less than 120. And again, if we're thinking about the specific coronary artery calcium score thresholds or cut points, we know that patients with a coronary artery calcium score of 300 or higher have a risk equivalent to a patient with a prior ASCVD event, and the hypertension guidelines are going to recommend treating those patients. But if we think about patients who are in that 130 to 139 group, if they have a coronary artery calcium score of 200 or 220 or greater, they're going to have a CVD risk equivalent to what we saw in the SPRINT trial. And those are patients, again, that we're going to want to think about treating to that lower, more aggressive, less than 120 number. Thank you for your attention, and happy to take any questions.
Hi, everyone. Thank you for joining us, and thank you to the speakers for all these great presentations. We'll go now to a Q&A. Unfortunately, Dr. Bhatt could not join us for the live Q&A this morning, but I'd like to welcome Dr. Shaw, Dr. Budoff, and Dr. Welcome for some discussion and questions from our audience. And I'd like to start with the first question to Matt. You've done extensive work in calcium scoring before you got into plaque quantification. So there's this question from the audience that asks, so how does plaque quantification perform compared to CAC? Is there any patients that you do CCTA for quantification? Is it with CAC 0, or even people that have positive CAC gain benefit of quantification?
Yeah, no, I mean, I think, we have to learn where each of these tests lie. I use CAC for prevention, asymptomatic populations, more in symptomatic populations. But I think, as Dr. Shaw showed so elegantly, there are really excellent data now emerging with primary prevention and CAC. And I think as the TRANSFORM and other trials, demonstrating Scott Hart 2 and all these other trials start showing us that we can use CT angioplaque in primary prevention, I think that we will shift. Certainly younger patients, CTA if you want to risk assess CAC well, in age under 40 for sure. Some people say age under 45. I don't know if Dr. Shaw has further thoughts on that. That was kind of her topic.
Matt, I'll jump in, but I think you answered it correctly. I think if you look at the extent of plaque, right, calcium scoring and total plaque volume will generally give you about the same amount of information. I think clinically we use quantification if we have a strong concern about the burden of non-calcified plaque, right? And so that added value. From a prognostic point of view, though, we largely don't have untreated non-calcified plaque. Most of the patients who are going to have a CT quantification of plaque, are on some form of therapies, which may change its prognostic significance. But, in terms of decision-making, if you are concerned about the non-calcified plaque, then, quantifying the plaque would be good. It is not, there was a recent ACC statement, a number of folks listening and on this call participated, including myself, not recommending to do plaque quantification in patients that don't have visual estimates of plaque. So that's one other key take-home message that we've seen that is important to guide clinical use of it.
Thank you.
Excellent. Yeah, well, and if we're talking about quantitative plaque, Leslie, I'll direct this question to you, Dr. Shah. Is there a meaningful change that you're looking for if you're doing serial assessment for how you're going to treat a patient?
You know, I think historically, all of we don't, the guidelines and everything do not like serial imaging because serial begets more serial begets more serial. You started at a 40-year-old, you know what's going to happen. But I think that the field is definitely moving that way. Nobody on this call would be fooled to think I could stop with that answer. And I'd love to hear other folks, Leandro and Matt's perspective on it. We don't actually know the answer to what is a meaningful change in total or non-calcified plaque volume. Absent that, we use somewhere around 20 cubic millimeters in total plaque volume as kind of an indicator that there has been progression. But, you can look at other things, right? New lesions, lengthening of a lesion that you can see visually. And then non-calcified plaque, we generally use around 10 cubic millimeters. But I will guarantee you that Matt will publish a paper in a year or so, or somebody else will publish a paper that will give us more refined estimates. I don't know if Dr. Budoff wants to comment as well.
Yeah, no, I think we're still trying to learn exactly what a meaningful change represents. But I would say that we're hoping the field towards non-calcified plaque volume. If you are going to track something, we all know the shortcomings of serial calcium scoring in statin patients. You see a slight increase in calcification, and we think that if you had a rise in calcified plaque and a reduction in non-calcified plaque, that would be stabilization, and your total plaque volume may not change at all. So there's a big consortium, including working with the Food and Drug Administration, the FDA, to try to get non-calcified plaque volume as a metric of, yes, your drug works. You can market it based on plaque changes, and that would be non-calcified plaque volume as the metric, if that does happen. And I think it will. It'll probably take about 3 years, but I think you'll see drugs approved now based on their change in plaque volume while awaiting perhaps large outcome studies.
Thank you. Very good. I think it's key also that if you're going to track changes, you need to use similar scanner, good quality scanner, and similar software, right?
100%.
For sure. Yeah, I think that's the most important thing, is that you need to be on a stable platform. And I would warn everybody against the shift from 256 or whatever we're using now, whatever numbers the vendors try to make up as far as more than 256, to photon counting scanners, where we're going to see a reduction. There's a nice study that showed 34% reduction in plaque using the exact same patient, just based on assessing it with as a photon counting scan versus a 256. So if you change platforms, especially to photon counting, your plaque volumes will drop, the noise goes down, and I think that's going to be a big problem in assessing serial change.
You have to be careful with matching the KV, correct? That's the big thing.
Yeah.
KV will change the composition of the plaque. You'll get more non-calcified, more calcified, et cetera. So if you're going to do serial prospectively, take care to match those parameters. If you get something from another institution, just be cautious if the technical parameters, especially KV, are quite different.
Exactly. Thank you very much. And last question to Dr. Walton. Thank you as well for joining us. I think we usually focus a lot and appropriately in LDL lowering, but hypertension is one of the main drivers, right, of plaque progression. So your lecture was right on point. And there was a question from the audience on age. How do we take age into account when we think about doing aggressive hypertensive control?
Yeah, this is a great question. We get asked all the time. So this was probably most closely studied in the SPRINT trial, which I showed you a lot of data from. And again, remember that SPRINT had a coronary calcium score of greater than 400 as one of the inclusion criteria. But in the SPRINT trial, even when they treated to less than 120, they found that when they looked closely at the age group above 75, which was one of the main things they wanted to look at in that trial, that we know that those patients are higher risk. But we found that the relative reduction in their risk from treating them to less than 120 was similar compared to younger patients. They looked at this in a number of different ways in the SPRINT trial. They also looked at patients who were older with markers of frailty. And again, they found that those patients were higher risk, but that treating them was equally efficacious. So I think there's a lot of good data to support treating older, higher risk patients, even potentially older, frail patients to less than 120. But again, I think important to, personalize risk for those patients and make an individualized decision. But we have a lot of good data that those patients do benefit from treating to the lower systolic blood pressure goals. And, the risk is higher in that group, but we know that higher risk patients are more likely to benefit from treatment. So I think that makes a lot of sense.
Thank you very much. Alison?
Yeah, no, I think that we probably, our time is up. So thank all of our speakers for joining us this morning. We appreciate you being here on a Saturday. For our audience that's listening, we're going to take a 5-minute break. So we'll have you join us back around 10:28.
Perfect.
Thanks all.
Hi, everyone. Welcome back. Next, it's a real honor to introduce someone that I think is very meaningful for all of us that do imaging and prevention and has really pushed this concept of imaging subclinical atherosclerosis for a long time. And this is Dr. Valentin Fuster. Dr. Fuster doesn't really need an introduction, but he's the president of Mount Sinai Fuster Heart Hospital and the physician-in-chief of the Mount Sinai Hospital. In addition, Dr. Fuster is the general director of the National Center for Cardiovascular Investigation, or CNIC, in Madrid, Spain. He's an author of more than 1,000 scientific articles with an H-index over 180, and in all the top journals. He was the editor-in-chief for the Journal of the American College of Cardiology from 2014 to 2024, really pushing this journal forward. Among his many achievements, it is noteworthy that Dr. Fuster is the only cardiologist to have received the highest awards for research from the 3 leading cardiovascular organizations: the American Heart Association with the Gold Medal and Research Achievement Award, the American College of Cardiology, Living Legend and Life Achievement Award in 2017, and the European Society of Cardiology with a Gold Medal. I now present to you Dr. Valentin Fuster.
Thank you. I am Valentin Fuster from New York, and I am very pleased and happy to participate in this symposium today. Let me start by saying that about 15 years ago, I decided to change my research from understanding cardiovascular disease to understand health. And this is the foundation that I have on the top, the SHE Foundation, that I developed 15 years ago, Science, Health, and Education. And that is to study health of the blood vessels, or even at the subclinical stage, particularly related to the heart and the brain, and therefore move into prevention. Now, in order to do such approach, we divided ages in 3 different, from birth to age 20, age 20 to 60, and age 60 to 100. It is interesting that this foundation, the SHE Foundation for Prevention, began at the time that already cardiovascular disease was beginning to increase again. These are the risk factors that was just published, that what happened between 2005, 2010, up to 2018, and you will see the increase in hypertension, the increase in obesity, and decrease in diabetes. Interestingly, also just published, you can see that 1, 2, or 3 of the risk factors have significant implications in mortality. This is going back to 1999. At that time, things were better, but not at this time. But I can go further. What about from the year 2020 to 2050? What is being predicted? Hypertension will increase, obesity will increase, and diabetes will increase. And these are the repercussions on coronary artery disease, on red, and in blue on a stroke. And this is related to the economics of these diseases that will be increasing. So the justification for prevention today is absolutely critical. We have to stop this. Let me now go into the work that we have done in the last 15 years, which is now being published at this time and in the next couple of years or so. We are talking about 5 different aspects that I will emphasize. At age 20 to 60, the imaging study PESA, with the 2 studies that we are now participating, the PRECAT and the REACT study. Then we will move also with imaging to the brain, and we will talk about the brain study. And then we'll go into education and SHE, 3 different ages. So let's now go into the process. We began 15 years ago with the PESA study, an imaging study in people between age 20 and age 60. The PESA in itself was age 45 or 40 to age 55, but we also include in this discussion what we learned between age 20 and age 60. This is the PESA study, began in 2010. We are dealing with over 4,000 people, 1,500 women, which actually are being followed between 2010 and 2029, every 3 years. What we do, first 2D and 3D vascular ultrasound of the femoral and carotid arteries. We do computed tomography for calcification of the coronary arteries or the calcium score. And we have also a sub-study with PET, positron emission tomography, and magnetic resonance imaging, again of the carotids and iliofemoral arteries. This program of imaging is actually associated with the phenotypes of the patients related to more than 4,000 parameters by artificial intelligence that we like to address, as well as the genetic studies in terms of genomics, transcriptomics, proteomics, etc. So let me now go into the data. This is the study that we developed over the last 15 years, which is an imaging study. Basically, it's 3D ultrasound in the carotid and iliofemoral region, in which with artificial intelligence, we actually look at where the plaques that are developing are present. Here we are. And then with artificial intelligence, we can quantify these plaques in these carotid and iliofemoral regions. Now, we have published a lot about this in the last 2 years, but I just want to make one point. What is the relationship between early disease or peripheral vascular disease, we call it, in the carotid and iliofemoral region with coronary artery disease? Can the peripheral vascular disease in the carotids and iliofemorals be a marker of what is happening in the coronary arteries? A critical question. And here we just obtained the data, and it's fascinating. Here in the vertical axis in the right, you have in green normal coronary arteries. This is coronary CT angiography. In yellow, mild, then moderate, and severe coronary artery disease. This is in the vertical axis. And in the horizontal axis, we have no disease in the carotid or iliofemoral region, carotid disease, femoral disease, and both. This is the early stages of disease in general. But let me tell you the following. If you look at the slide carefully, if we find carotid and femoral disease, what we can see is the chances of having coronary artery disease in the initial and moderate stages are close to 75%. On the other hand, if we go to the left of the slide, if there is no disease of the carotid or iliofemoral region, the chances of having significant coronary artery disease are almost zero. So what we are really saying is, here is a technology, it's quite economic. It will be available to the public probably within the next year or two. And looking at early disease in the carotid and iliofemoral region, we can already predict what goes on in the coronary arteries and apply this economic technology around the world. So this is the PESA study with fantastic or interesting data, and is now leading to 2 trials. And let me start with the pre-cut trial. This is a study of 2,000 young people, aged 30 to 49 years, with an LDL cholesterol more than 70 milligrams DL that we know is already a parameter that disease is beginning, particularly in the iliofemoral region. And what we actually did is to start the study having 1,000 of these people treated with subcutaneous inclisiran twice a year. Something very important. We found at the beginning that young people don't like statins. So here we have entering patients one after the other very easily at young age with the use of inclisiran versus in blue is placebo, or I would say control rather. And these people are being followed for 5 years. Now, what we are looking at is progression of disease in the iliofemoral and carotid regions that we know actually are associated with what goes on in the coronary arteries. You will say progression is not enough. We like to see events. Well, events at this young age is not the reality, but we already have data, as you can see in the bioimage study that we just published 1.5 years ago, in which progression of disease at a follow-up of 36 months means cardiac mortality, all-cause mortality. So we already have progression of disease at relatively young people, but we know this eventually means events. The bioimage study was in people over age of 60, but telling us very important data. Progression of disease in the iliofemoral or carotid region means mortality. And what we mean at a younger age means this will be trouble later in life. This is the study. But what about the REACT study? Our pre-cut study of near 2,000 people in the REACT is much larger. This is a study between Denmark and Madrid, Spain, where we have the original PESA study in the National Center of Cardiovascular Investigation. It's the same than before than the pre-cut study, but here we have 16,000 people. And in these 16,000 people, a large proportion will have also CT angiography at the same time that carotid and iliofemoral 3D ultrasound. We already enter about 8,000 people in the study. And in the pre-cut study, we almost enter half of the people of the 2,000 that we mentioned. So this, in our view, we really are predicting the future. What is the future? The future will be with very simple technology of imaging in the carotid and iliofemoral region. We were able to predict what goes on in the coronary arteries and act much quicker than the disease before has developed from symptoms and so forth. So this is exciting because we can go all over the world, and actually we are starting also a projection of this REACT study in India at the present time, and we are very excited. So we see the future in the next 5-10 years. Risk factor profile, of course. Look at the iliofemoral region, which is where the disease tends to start. And if we see disease there, we can begin to attack the risk factors that we identify in trying to prevent progression of the disease. We are excited about it. Well, from the heart and the peripheral vasculature, we move to the brain. Very fascinating with all new technology. Now we are age 60 to 100. What the problem is? The problem is actually cognitive dysfunction. This is what we are going after. Let me present an introduction. Alzheimer's, about 125 years ago, said my disease is a disease of the arteries and of the small cerebral arteries. Very interesting, isn't it? So what we now came about, the following hypothesis, that the same risk factors that affect the heart and the peripheral vasculature may affect the brain and the arterial system. And actually, this is really what we are beginning to find. And this is now part of my presentation today. About 2-3 years ago, as part of the PESA study, we did a study in which patients with at least 2 risk factors of the 3, hypertension or high cholesterol or diabetes, 2 of the risk factors in these patients, when we did positron emission tomography from baseline, this is the uptake of glucose, we saw significant decrease after about 4 or 5 years. Interestingly, we had data, although it's retrospective data, in which magnetic resonance imaging of flow to the brain here in the vertical axis is actually correlated with the uptake of glucose decreasing with positron emission tomography, telling us since there is no large vessel disease, no significant obstructive carotid disease, or disease in the circle of Willis. This means the microvasculature may be the cause of the decreased uptake of glucose in the brain because of a decreased flow, because microvascular disease. And this is what the pathologists are beginning to find today, and that is the risk factors that I mentioned before, particularly hypertension, diabetes, and hypercholesterolemia, affect the small vessels of the brain. And this is actually not atherosclerotic disease. This is actually intimal and medial thickening. The same when we talk about medial and intimal thickening of the carotid arteries. Now, in the brain, this is very important because it might decrease flow and the uptake of glucose and leading to cognitive dysfunction. And this is actually has led us to develop the so-called PESA brain study. The PESA brain study is about 1,000 people, 1,000 participants with an average age of 55 years that we are following with all the imaging technologies that we mentioned. And then we look at cognitive function of the brain in the follow-up with a number of years. And then we also look, of course, at the biomarkers of that can lead to cognitive dysfunction. We believe, and many others believe very strongly, that great part of dementia relates to risk factors that affect the vasculature of the heart and of the large arteries, but in this case, affecting the microvascular of the brain. And in fact, these are two studies just published with the following. Of all cases of cognitive impairment and dementia, cardiovascular risk factors contribute directly to 20% of the type of dementia that is vascular dementia, but such risk factors participate in the majority of patients who have cognitive dysfunction, including Alzheimer's disease. And I'd like to make a comment here. When we look, and I presented the slide of the uptake of glucose in the brain that was decreased with risk factors, let me say that the regions of the brain in which the uptake was less actually were the same regions that Alzheimer's disease develops. So we believe Alzheimer's disease is a complex entity, but in this entity may progress because of the vasculature if it is affected by the risk factors I mentioned, particularly the microvasculature. And this leads to a recent publication of ours and other publications, which actually puts together something that we believe is critical in dementia. Here we have the risk factors I mentioned in the middle: hypertension, diabetes, high cholesterol. This is education at young age, and this is something very important, and that is, can we affect dementia even at latest stages of life? And here is an issue that is becoming very critical, and that is, not only you can try to control the risk factors at any age, but also the social isolation make people to be more socially open, motivation and exercise. And actually the data is already evolving. For example, the data of it was just published recently, 2 studies in which you can fast stop or prevent the fast motion of cognitive dysfunction by getting out of social isolation, doing exercise, and starting with motivating tools in life. These, the results can be already be positive in 1 year, where, as shown in this lowest study in China, when you control the risk factors, you can have some success, but it takes 2, 3, or 4 years. But it's just very important to realize even cognitive dysfunction that is so common and the risk factors are so important, it can be ameliorated and perhaps preventing this progression by being behaviorally, socially, not to be isolated, to be motivated, to do exercise, and certainly control of the risk factors as mentioned, that is more of a slow process. And now I'd like to finish by saying that all of this is very fascinating, but if we have to have an impact, there is nothing better than early stages in life. And here is one of the main driving forces of our foundation, Science, Health, and Education, which is primordial prevention. And the concept is very simple. At younger age, the number of receptors of the brain are a small number, compared with a chaotic number of centers and interrelationships and density in later ages. What that means is if we tell something to a child under the age of 10, 12 years, this is actually anchoring to the brain and it stays there. When we talk to an adult, there are so many centers and interaction between the centers that it seems one thing comes from one ear, gets into the other. So there is nothing better than try to teach health at young age, and perhaps this will persist. Remember yourselves, what you are today, how you are, with your character has a lot to do with your exposure in the first 10, 12 years of life, because it stays there. This was our concept. So we began 4 randomized projects in children, actually in randomizing them into 2 groups. One group was treated. How you treat? Well, you instruct, you educate how the body works, food habits, physical activity, and how to control the emotions, to be sure that when they confront drugs, alcohol, etc., in older age, they are able to say no. What we really infuse in these kids is actually self-esteem. These 4 studies involve more than 7,000 children, and half of them were actually served as controls. I don't go into the details of the study because I don't have the time, but 3 conclusions evolved. The first, in the group that is being treated or instructed, the adherence is very important. The results are much better. Second, the control groups, interestingly, in the school system, which is where we started our projects, the control groups did reasonably well. If they are in an environment of health, they try to follow some of the rules, very important environment. And the third issue is sustainability. What we found is you have to instruct maybe every 3, 4, or 5 years, and then the results are exponential. And that is a first instruction within the first 12 years of life is important, but later on, probably reinstruction actually makes the results exponential. We have data until age 15 now. What will happen at age 60? I hope that what we learn at young age about health, the education about health, will be sustained. And this relates to the American College of Cardiology in June. We are going to instruct 50 cardiologists, later on 200 and more, into what we are talking about, which is primordial prevention. We call for applications of cardiologists, the American College of Cardiology, and large number want to participate, but we want to start with 50, that then they will go to the communities, and they will go to the families. The family is critically important, and this is why the environment we mentioned was critical. One of the results was you need an environment, and perhaps the family is important, and we are going to train them to train society on primordial prevention. So let me just by finish in saying these are 5 aspects that we try to tell you we have been working in the last 15 years, and the results are evolving now. The imaging study with PESA, and that is carotid and iliofemoral 3D ultrasound, a future. The pre-cut and the REACT study, starting to work on these people very soon in time to prevent, in this case, LDL cholesterol that are elevated, and other risk factors. The brain, how important is to realize, and that is everything may start early. and the brain slowly, the microvasculature can be affected. That's the importance of prevention, not only of heart disease, but also of brain dysfunction. And finally, the issue of, in a way, primordial prevention, which is the best time probably to educate society to really behave later on in trying to prevent cardiovascular disease and cognitive dysfunction. So I finish by saying we moved 15 years ago from trying to understand cardiovascular disease to understand health. And here we are today, trying to identify blood vessels that are beginning to have subclinical disease in the cardiovascular area, the heart, and the brain, and so forth. Prevention is the critical of the future. 3 different ages, 3 different approaches. Thank you.
Hi, everyone. Well, that was amazing. Thank you so much, Dr. Fuster, always pushing the knowledge forward. We're really thankful that you were here. And now we're going to be shifting gears from the first 2 sessions. We're going to be moving into carotid plaque assessment and systemic atherosclerosis. These sessions presenters both come from Madrid, Spain. We have Dr. Borja Ibáñez from the Spanish National Center for Cardiovascular Research, who will be discussing carotid plaque assessment with multimodality imaging, ultrasound, MR, and CTA, phenotype, burden, and the concept of vulnerable plaque. And then we'll have Dr. Beatriz Lopez Melgar from La Princesa University Hospital, who will be discussing non-coronary vascular plaque metrics for risk reclassification, what it adds beyond CAC and CCTA. Welcome to you both.
Thank you very much. Thank you, Leandro, Alison. It is a great pleasure to be here again within the symposium and present some of our science related to the carotid or peripheral arteries plaque assessment by different imaging modalities. I don't have any conflicts of interest to declare. So atherosclerosis is a systemic disease. It is well known that once one territory is affected, all the others are either in progress of disease initiation or have already the disease. In fact, we have observed this within our PESA cohort study that I'm going to very brief summarize of what is this study because I'm going to be presenting few of our findings. So this is a cohort study in middle-aged asymptomatic subjects between 40 and 55 years of age, both male and female, more than 4,000 of them, that they have undergone serial screening for atherosclerosis by using vascular ultrasound in the carotids and femoral arteries, calcium scoring of the coronary arteries, and also in a subset of them, they undergo also what we call advanced imaging, which is magnetic resonance imaging and a PET-CT exam. So this is clearly a multimodality imaging study. Also, we have some blood sampling paired with this imaging screening, and we are repeating this every 3 years. So far, we have done more than 15 years follow-up, and we have very exciting data about this systemic disease nature of atherosclerosis and also how it progresses. Here you can see one of the main findings of our PESA cohort study, which clearly summarizes that atherosclerosis is truly a systemic disease. In this apparently healthy population between 40 and 55 years of age, you can see that silent atherosclerosis is present in more than 70% of male and in 50% of women. So this is equally distributed in different territories. And more probably, you can see that the femoral arteries is more prevalent for males, and this occurs similarly in women, even though the difference between femoral and carotid prevalence is different for females and for males. But clearly, you can see here that all the different territories are affected to a big extent, so clearly summarizing that in a contemporaneous study cohort, we can clearly mention that atherosclerosis is a systemic disease. Also, another very important finding for the matter of what we are going to be discussing today is that we have observed that atherosclerosis starts or may start very early in life. In fact, you can see that in our PESA cohort study, the youngest strata was subjects between 40 and 44 years of age, and you can see that close to 40% of male and 20% of female, they already had atherosclerosis. So we realized at that moment that most probably we started late, and if we want to target the early onset of atherosclerosis, even younger populations might be targeted, and I will be commenting on this in subsequent slides. So here we can see a classical slide of how atherosclerosis starts. Starts very early in life, as I have mentioned, and then starts with the deposition of lipids and inflammatory material within the arterial walls, and this is progressively through through many decades, and then after a significant exposure of different risk factors and buildup of atherosclerotic plaques, later in the process, these atherosclerotic plaques can get complicated and drive clinical manifestations of atherosclerosis. So it's very important that until very recently, there was a paradox because it was well known that atherosclerosis was a process that might start very early in life. Also, we have tools, imaging tools to identify this atherosclerosis, but all the different prevention efforts are done either when the clinical manifestations occur or close to that when the burden of risk factors is very high. So this window of opportunity that can be identified by imaging, that is the early onset of cellular atherosclerosis, is a window of opportunity for prevention that has not been explored sufficiently in the previous years. And in fact, an intervention that is undertaken very early in this process should have a long-term effect, so therefore is tackling long-term risk, and the effect size of an intervention is expected to be very large. While an intervention, as is being done classically until now, done close to clinical manifestations, this is a short-term, this is tackling the short-term risk, and the effect size is anticipated to be much lower compared to an intervention performed long before in life. So why it is relevant to target peripheral atherosclerosis or to target atherosclerosis? The traditional view is that atherosclerosis in the coronaries should be identified to prevent acute coronary syndrome, atherosclerosis in the carotids should be screened to prevent a stroke, and atherosclerosis in femorals should be performed to prevent peripheral artery disease. But this is only predicting the short-term risk, and this is too late. The modern view, and to perform primary prevention much earlier in life, is that imaging is not to identify where the event is going to happen, but is a marker of systemic disease. So when there is any vascular bed with atherosclerosis, it clearly shows that there is vulnerability to risk factors, and therefore it is clearly showing that this subject is at a very, very high risk. So this is a clearly change. So this is why targeting peripheral atherosclerosis has a relevant matter as a marker for the presence of the asymptomatic disease. It's very important, however, because if we want to convince the society that targeting or identification of early atherosclerosis in the peripheral arteries has a relevant aspect, it should be somehow supported that this is associated with the presence of atherosclerosis in the coronary arteries, because the mindset of the cardiologists, scientists, and the population is that if you want to prevent myocardial infarction, it should be identified something that is related to atherosclerosis in the coronary arteries. This is a confidential slide. Still is up an article that hopefully will be published or will be accepted very soon. I'm sharing this confidentially. You can see that this is from our PESA cohort study, and we have done a correlation between the presence of peripheral atherosclerosis, carotids and femorals, and presence of atherosclerosis in the coronary disease. Here you can see the group who do not have any disease in the peripheral arteries. They barely have any coronary artery disease, while subjects who have presence of atherosclerosis, both in carotids and femorals, they have a significantly higher proportion of subjects also with concurrent coronary artery atherosclerosis. And these different colors are the different degrees of coronary artery atherosclerosis. So clearly suggesting that the presence of peripheral atherosclerosis is associated with the presence of coronary atherosclerosis, even if it is not significantly severe in stenosing the lumen of the artery. So therefore, supporting that the identification of atherosclerosis in the peripheral arteries is a good surrogate for atherosclerosis in the coronary arteries. As to which is the best modality for the identification and characterization of atherosclerosis or plaques in carotids and femoral, which is the main topic for my presentation, I'm going to be focusing on the three main modalities, which is vascular ultrasound, magnetic resonance imaging, and compute tomography for peripheral arteries atherosclerosis. To make the long story short, vascular ultrasound is clearly the most sensitive techniques for plaque detection and quantification. And also is very important because this is critical for the longitudinal evaluation of the progression of the disease. And this is especially relevant for primary prevention because even smaller plaques that might not be visualized by the other imaging modalities can be visualized by vascular ultrasound. And therefore, this is why in primary prevention, when you are expected to identify small plaques, then this technique is probably the most well suited for that. However, if you want to go for plaque characterization and identify more short-term risks, so close to the secondary prevention, clearly there are the versatility of magnetic resonance imaging is superb, as I'm going to be showing in the next slides. And also recently, the value of CT scanning, the CT scanning, especially for the identification of calcification and patterns of calcification, also they add some value for this. So clearly, it's not which is the best modality for the atherosclerosis identification of peripheral arteries, but what is the goal for this identification? Is primary prevention, identification of the disease, yes, no, and its volume, or it is the composition more associated with the potential events in the short term? Therefore, if you want to prevent something that is very early in the atherosclerosis, vascular ultrasound is probably the most and the well-suited technology. Well, if you want to identify something in the short term, as I have mentioned, most probably plaque characterization plays a better role. Here I want to make a disclosure that whenever we are talking about the plaque composition and the vulnerability of the plaques, it has to be well acknowledged that this concept of vulnerable plaque has been the matter of intense discussion. This is a very interesting article by Valentin Fulter, with whom I have been working for more than 25 years, which is talking about the myth of the vulnerable plaque. This is quite provocative title, but what is behind here is that it's very important also to bear in mind that there are many plaques simultaneously in the coronaries and in the peripheral arteries that have the characteristics of vulnerability, and the chance for any of these plaques to rupture within the next months and perform and be the basis for an acute coronary syndrome or a stroke is significantly low. So therefore, the diagnostic yield for these tools is clearly questionable. So this is why some researchers believe that the vulnerable plaque concept is something that is more for the imaging and for the discussions than for any impact on prevention. So why risk factors are associated with adverse events and why screening of atherosclerosis is relevant is because risk factors clearly are associated to a great extent with events through the build-up, presence and progression of silent atherosclerosis. So this is why if you want to better predict which subjects are going to have an event, rather than going only to risk factors, it's very important to go to intermediate risk factor or to intermediate actor, which is atherosclerosis. So this is why identification of atherosclerosis very early has been proposed as a great precision tool to better predict the risk of individuals. In fact, we demonstrated this in the bioimage study, which was performed very early in the year 2005. In this case, the population was again a primary prevention population, slightly older than the PESA population, 70 years of age, of mean age, and all of them underwent vascular ultrasound of the carotid arteries and also coronary calcification by CT scanning. And you can see that even after adjusting for the classical risk factors or for the cardiovascular risk factors, those individuals who have a larger plaque burden in the carotids, they have a significant increase in the incidence of these ischemic events. And this was similar for the coronary artery calcification. So clearly showing that the identification of atherosclerosis improves the prediction risk of only risk factors. And we have done a longer follow-up for this bioimage study. We published this a few months ago. And in this case, what we did is from the entire population of the bioimage study, which was more than 5,700 individuals undergoing carotid ultrasound. In that case, we were not doing femoral ultrasound that we have incorporated later. We have performed a very long-term follow-up of 12 years of median follow-up. And as you can see here, even in the long term, after adjusting for classical risk factors, the presence and burden of carotid atherosclerosis only by vascular ultrasound, so only the volume of plaques, was clearly associated with all-cause mortality in the long term. And this is after adjusting for any risk factors, and this is very relevant. And also a few subset of them, close to 1,000, underwent a second vascular ultrasound of the carotids 9 years after the first scanning. And you can see here that even after adjusting for the presence of atherosclerosis in the carotids at baseline, subjects with progression of atherosclerosis, which is the enlargement of plaques or new onset of plaques, is associated with a clearly increase in all-cause mortality. So therefore showing that in primary prevention in the long term, identification and quantification of plaques in the peripheral arteries is associated with long-term ischemic events and also long-term all-cause mortality. Now we are performing another cohort study, which is the REACT cohort study in collaboration between Spain and Denmark, 16,000 asymptomatic subjects between 18 and 70 years of age. And in this case, we are performing a very comprehensive multimodality imaging paired to other biomarkers, very novel biomarkers, digital biomarkers, etc. And in this case, what we're pursuing is to see what is the actual prevalence of atherosclerosis across life since very early in life, and later on in a second stage we are going to perform a randomized clinical trial testing the concept that the treatment of risk factors based on imaging and not based on the classical equations, it has a clear impact on the short-term progression of atherosclerosis and also in the long-term incidence of adverse events. We are also working on the fine refinement of the vascular ultrasound. We are using very well-developed three-dimensional vascular probes, but this is not going to be implemented worldwide. And if we want this to be something that is universal, we have to develop a tool that is easy to access and is easy to acquire by non-experts, and also who has an automatic quantification. So within this REACT, and thanks to additional grants, we are changing this portable ultrasound in collaboration with Philips, and we are using artificial intelligence to assist completely the acquisition of carotid imaging and also femoral imaging, and also a complete automatic quantification. So therefore, very soon we are going to be ready to have something that can be applied by non-experts in any environment, not necessarily in a hospital, and therefore we're going to be able to identify the presence of atherosclerosis and its burden in a very easy manner. When it comes to the magnetic resonance imaging, as I mentioned, this is more for the short-term risk evaluation. It has been demonstrated mostly in subjects with symptomatic peripheral artery disease, so with symptomatic carotid disease, patients undergoing endarterectomy or similar, that different features of magnetic resonance imaging within the plaques, certainly intraplaque hemorrhage, is associated clearly with a recurrent ischemic events, in this case a stroke, and also events that are not stroke but also coronary heart disease events. So in this case, I'm showing this that is symptomatic carotid disease, but also it's fair to acknowledge that also there have been other studies in which these asymptomatic subjects, even though they were old population, 72 years of mean, also magnetic resonance imaging and identification of intraplaque hemorrhage has been associated with a significant increase in the incidence of a stroke in the follow-up and also on the coronary heart disease, as I mentioned before. So therefore, again, showing that these more developed techniques, in this case magnetic resonance imaging, can complement the identification of atherosclerosis, but this is more close to the secondary prevention because this is some sort of secondary prevention tool. And finally, there have been some studies, even though the evidence is weaker than that from magnetic resonance imaging, showing that using compute tomography, also you can identify some features, especially these calcification patterns that are associated for recurrent strokes. In this case, again, this is a symptomatic population, patients with carotid disease, undergoing carotid endarterectomies in some cases, and in this case it was demonstrated that this pattern of the positive rim sign, which can be seen in this type 6, was clearly associated with a significant increase of ischemic strokes in the follow-up. Again, this is the evidence is weaker, but still there might be some value in using a CT for this better depiction of the future events in this population. So finally, this is my second last slide. This is very important, that this concept that we have to deliver very frequently, that atherosclerosis it has been thought that it was an irreversible phenomenon that could be either halted or not, but it couldn't be regressed. But this is not the case. If atherosclerosis is detected very early in the process, which means that you have to do a screening in young population, it can be not only stopped but also completely regressed. As you can see here, and this is from the PESA population, in the x-axis is the global plaque volume, carotids plus femorals at baseline, and in the y-axis is carotid and femoral plaque volume 6 years follow-up, and each of these dots is an individual, and you will see those who are at the bottom part of the slide that are green dots. They are subjects who had atherosclerosis at baseline, and they have changed their risk factors, and the atherosclerosis was completely regressed at 6 years follow-up. Our speculation is that if we're promoting an aggressive risk factor control in subjects in which we identify this atherosclerosis very early in their life, eventually this 8% of complete remission could be significantly increased to 60-70% of complete remission of plaques. So in conclusion, carotid imaging offers the potential across the spectrum of carotid atherosclerosis, and I should say that this applies for all peripheral arteries, so it's not only carotids, but carotids plus femorals. Clearly, vascular ultrasound is the winner for very early and primary prevention because it can identify with a better resolution plaques, or with a better sensitivity plaques, even a smaller volume, while magnetic resonance imaging is a very good modality for determining the composition of the plaques that eventually might be associated with short-term risk, so therefore more in the secondary prevention. There is less evidence for CT, but there might be some value or some role for it. The field needs to move from for primary prevention, and eventually this concept of early identification of atherosclerosis by imaging to drive interventions and eventually cure this process is extremely relevant, and for that the winner technology is going to be vascular ultrasound for the different reasons that we have discussed today. And finally, vascular ultrasound technology needs to evolve into something that is cheap, easy to use, and automatic quantification, or hopefully within the next years we are going to be able to deliver this, and this is going to be available worldwide. Thank you very much for your attention.
So, hello, my name is Beatriz Lopez Melgar, and it's an honor to present at this symposium a talk on non-coronary vascular plaque metrics for risk reclassification, what adds beyond calcium score and CCTA angiography. These are my disclosures. And first of all, if we want to compare imaging markers in atherosclerosis, we must understand what determines each marker's performance in predicting cardiovascular risk. And these factors are mainly three. First, the natural history of the disease, to know when to use its technique and in which patient profile. Second, the sensitivity of each technique and how it detects plaque burden. And third, to understand the systemic nature of atherosclerosis, which vascular territories should be explored, and how atherosclerosis progresses throughout the vascular system. So let us start with the first factor, the natural history of atherosclerosis. It has been revealed by large primary prevention studies. For example, the PESA study, that showed that the disease is highly prevalent in young and middle-aged asymptomatic individuals, more in the femoral territory, followed by the carotid territory by vascular ultrasound, and less common in the coronary arteries by calcium score. This indicates that ultrasound of non-coronary territories, especially the femoral territory, is more sensitive for detecting early stages of the disease. Although one might think that this is because calcium score only detects advanced stages of the disease, namely calcification, coronary CT angiography studies also show a higher prevalence of carotid plaque compared to coronary plaque. Moreover, it's rare to find coronary disease without carotid plaque by both calcium score and CCTA, especially when coronary plaque burden is high. However, the evidence comparing both carotid plaque assessed by vascular ultrasound and coronary plaque assessed by CCTA is limited and mostly based on smaller studies like this one that I am presenting to you. But altogether, it seems that the development of atherosclerosis follows a sequence, and its detection depends on the vascular territory explored and the imaging technique used, which is something that we need to take into account as it may affect the performance and also the interpretation of plaque markers. And reinforcing this same idea, in patients with familial hypercholesterolemia, carotid plaque detection has been shown to precede both calcium score and coronary plaques by CCTA. Even atherosclerosis can be detected as early as 17 years of age with vascular ultrasound, compared with 31 years using CCTA, as reported in this recent publication from JACC. Consequently, this study also showed that a protocol combining multiple vascular territories and imaging techniques with the potential for earlier detection improves also the prediction of events in these young patients with FH. But not only age is important, sex influences the interpretation and prognostic value of atherosclerosis-based biomarkers. And as suggested by PESA's study, a sex modifying effect is seen in the detection and in the onset of atherosclerosis markers, with women developing atherosclerosis roughly 10 years later than men. Also, women converted to a positive calcium score 10 years later than men, as published by CAC Consortium study previously. But what is more important, the prognostic impact of this effect has been now confirmed by a recent analysis from the MESA study. Calcium score is still the one that more effectively predicts overall cardiovascular events, but in an analysis subgroup, carotid plaque showed that it's a strong association with incident cardiovascular events was for younger adults, particularly in women. So in the end, this illustrates the complementary role of calcium score and vascular ultrasounds, with carotid plaque assessment being especially valuable in young individuals and women. This is because each technique reflects different stages of atherosclerosis disease. And nevertheless, despite differences in the onset and detection of atherosclerosis by age, sex, vascular territory, and imaging technique, calcium score still remains the most robust marker for predicting cardiovascular risk, especially for its negative predictive value. This is the power of zero that has been widely discussed, particularly its value in the long term. However, up to 1/3 of patients with a calcium score of 0 have carotid plaques. And this finding has been associated with the subsequent development of calcium score and the also cardiovascular disease in the long term, as shown in this MESA study analysis. So in other words, the presence of carotid plaque in individuals with a calcium score of 0 identifies those at a higher long-term risk, improving the identification of patients with this risk, let's say residual risk. And what happens the other way around when non-coronary plaque is 0? Could it act as a gatekeeper for calcium score? Well, this question can only be answered through a systemic assessment of atherosclerosis that should include femoral territory in addition to the carotid territory. As PESA study showed us, the absence of femoral plaque confers a 67% probability of no plaque in other vascular territories, including coronary calcium, which is even higher when both femoral and carotid plaques were absent. And look at atherosclerosis progression. It is detected 5 to 10 times more frequently by vascular ultrasound than by calcium score. Therefore, when carotid and femoral plaques do not progress, calcium score progression is really uncommon, no more than 80% as reported by PESA. Well, although data in older population are still needed, in younger individuals, maybe calcium score could be avoided if no plaque is confirmed in a multi-territory assessment. And this is indeed an interesting and very interesting hypothesis for future research. And what happens when we compare the negative predictive value of different biomarkers? Calcium score still shows the greatest downward shift in estimated cardiovascular disease risks, but followed by carotid plaque detection, likely due to its higher prevalence compared to calcium score. And both are far above other clinical and biochemical markers. This is the power zero with current evidence still belongs to image-based biomarkers, and especially the calcium score. And just one thought on clinical practice guidelines, how they have incorporated this evidence. Well, it's true that plaque detection has gained much interest in the most recent European and American guidelines, but they simply state the concept of carotid and or femoral plaque detection for assessing cardiovascular risk. And whether a plaque is present or absent, we are completely missing the full spectrum of atherosclerosis and the actual burden in the individual, as I try to represent in this slide. Therefore, if non-coronary vascular plaque wants to compete against calcium score and CCTA, we need to quantify plaque burden. And as you can see here, when comparing the ability of non-coronary plaque to predict events with most robust calcium score, the differences are very obvious, and they depend mainly on the measure used. Most approaches, the ones that use CIMT or simple assessment of carotid plaque presence, well, they perform worse than calcium score for predicting events. Other markers like semi-quantitative carotid plaque score based on the number of plaques or measures of carotid plaque burden in millimeters square. Well, these markers, semi-quantitative markers, nearly match the predictive value of calcium score. But the novelty here is the carotid plaque volume, the marker that more closely reflects total plaque burden among others. And it has shown to outperform calcium score for the first time in predicting all-cause mortality, as recently shown in the bioimage study, a study performed in asymptomatic American population. So in short, it seems that measures that better reflect the extent and severity of non-coronary disease may be able to compete with calcium score in risk prediction. And to summarize, I have to acknowledge that calcium score is still the strongest risk marker, backed by lots of studies. On the other hand, carotid plaque burden has also evidence, but is less consistent because there are different ways to measure it. And researchers haven't agreed on one standard use like with calcium score. Also, calcium score has better ability to predict cardiovascular events, but new 3D ultrasound measurements are starting to match or even beat calcium score. And in addition, when we choose how to assess atherosclerosis, we should consider age, sex, location, and disease stage, not just to detect disease, but also to predict better the events, and even considering multi-territorial and multimodal approaches in some clinical context. And well, a simple, low-cost, highly available, non-radiating test like ultrasound can help overcome the limits of access, radiation, and the lack of standardization of plaque metrics in tests like the coronary CT angiography, which is still controversial for risk assessment in people without symptoms. Well, thank you very much for your attention, and I'm happy to hear your questions and suggestions.
All right, welcome back. Thank you so much, Dr. Ibanez and Lopez Melgar. Those were excellent presentations. And I think for those of us, at least based in the US, really highlights sort of the differences in how we think about imaging. So we're going to take some questions from our audience. So the first question, Dr. Ibanez, I'm going to ask you. Given the variability and distribution of atherosclerosis, when should carotid or peripheral arterial imaging be considered for detecting subclinical disease as opposed to just coronary atherosclerosis, which I think we spend a lot of time on here in the US?
Yeah, this is a great question. So first of all, it's important to remark that we are generating the evidence because we have highlighted in our presentations, we are proposing that we should move much earlier for the screening for atherosclerosis. So in that sense, it might be the case that there is some atherosclerosis in peripheral arteries or even in the coronary arteries without the presence of any calcification. So this is why we are advocating for doing this. And as to when it would be good to perform this in the CAC0 subject, eventually we advocate that eventually this should be done since very early in life, eventually since 20 years of age. But of course, this is not going to be cost effective for the entire population. So this is why we are generating some novel risk scores that are not giving the odds of having an MI within 10 years, as Prevent or SCORE2 are doing, but giving you what are the odds of having silent atherosclerosis at that exact moment. And we believe that this is going to serve as a gatekeeper. So eventually we're envisioning a future, maybe in 2 to 5 years from now, that first of all, this new risk score should be applied, and in those subjects exceeding a certain threshold, peripheral atherosclerosis screening should be performed. And we're advocating for peripherals, as we have presented in our presentation, because of course what is going to be associated with events is the coronary artery atherosclerosis, but they are very tightly correlated. So therefore, we can assume that in a person having atherosclerosis in peripheral arteries, it is expected that they are going to develop also coronary atherosclerosis.
Yeah, thank you very much. Very important question. The second question we have here for Beatriz, it says, what role does aortic atherosclerosis play compared to carotid or femoral? And have studies evaluated this? We sometimes detect aortic plaque before coronary atherosclerosis.
Yes, that's a very important point because atherosclerosis is important despite the territory where you are detecting it. Unfortunately, the role of aortic atherosclerosis is less better established than the atherosclerosis that we found in the carotid and femoral arteries because more recent studies are being focused in these peripheral arteries and in the calcium score instead of the aorta. But for sure, it is relevant. We don't have robust evidence to establish when to use it and how to use it, and that is why I'm afraid it is not included in the guidelines up to date. No, but for sure it's important. If we find atherosclerosis in the aorta, we should take it into account for sure.
Yeah, I agree. We found in data in Montefiore, we looked at patients with LDL over 190, and we looked at people that had a CT scan, and those that had no calcium in the coronaries but had calcium in the aorta had still higher mortality. So I think it's important, and how we treat it, we're still learning about it, right? But so important. What do you think, Borja? You're muted, I think.
Yes, I muted because I was applying passive mic here. So yeah, it is true that aorta calcification is some sort of atherosclerosis as well, but it's more or less a late phenomenon. So even if you have incidental calcification in the vessel, coronary arteries, but also in the aorta, we think that this is enough to consider that the subject is at higher risk. So this way, this practice is not very well established with a protocol to undergo some calcification in the aorta. Eventually, any calcification in the artery should be considered as a high vulnerability to risk factor. So therefore, this should be enough to put this patient into a higher risk category.
Okay, so here's another question, which I think is really relevant, especially since we don't do quite as much ultrasound screening in the US. But since carotid ultrasound is highly operator dependent, how do we account for differences in technician impact on plaque characterization and further risk assessment? How do you handle that, Dr. Ibanez?
Well, this is a great question, and in fact, it has been one of the reasons why carotid and femoral atherosclerosis screening has not been widely used, because there is a lot of variability between different equipment, different probes, 2D, 3D, and also the high dependence on the operator. So starting for the future, as we have presented, we think that eventually we should develop some easier to use and AI-assisted devices. So more or less this can be harmonized across the different protocols and the different centers and equipments. But until that moment comes, we think that eventually, if you would like to go for the actual plaque volume determination, of course, this needs to be done with a very accurate protocol and eventually with this 3D vascular ultrasound equipment. But this is more for research purposes and to generate evidence. But that is for what patients matters. As long as you can identify whether there are atherosclerotic plaques or not in carotids and femorals, we think that this is enough to put the patient into a high-risk category. And then, of course, the volume of the plaque matters. So eventually, having visualized a small plaque is less of high risk than having a very large plaque. So we think that eventually, with any imaging equipment, as long as you are able to detect and determine that is atherosclerosis-free or has atherosclerosis, this might be enough in order to take this into account for treatment decisions because this patient is, of course, at high risk.
There's also I think 3D and volume matters, especially if you want to monitor people. No, plaque detection is great for reassessing risk, but if you want to monitor that, these new algorithms guided by AI, for sure they are going to help for the following up of the patients. So.
Yeah, and also for the audience, which is very interested in these practical issues, there are no 3D vascular probes in the market anymore, because the one that we have been using for a long time is from Philips, but this is not in the market anymore because they're moving their pipeline to this 2D portable solution that can generate some 3D volumes out of this. So this is why, as Beatriz mentioned, this is very good for tracking and for research purposes. But as it comes for clinics, we think that eventually in the close future is going to be able to perform this with any vascular probe and enough to put the patient into higher or lower risk category.
Thank you so much. In particular, if there are going to be multiple measurements, you have no radiation, so that's great. So we have another question for Dr. Melgar. The question is on sex differences. You showed some sex differences in the territory involved already between ultrasound and CAC. And how do you take these differences in consideration on when you start screening or when you do follow-up or how you intensify therapies?
Yes, but regarding sex differences, they have been detected not only in ultrasound, but also in the calcium score. There are very nice works published by the calcium consortium at the BESA study that show how a calcium score also develops with 10 years of delay in comparison to comparing men and women. So I think this is not translating a question on the technique or a question on the, they are more likely to be showing the differences in the natural history of the disease, how it develops quite late in women in compared to men. When we look at the at middle-aged and young and middle-aged individuals, because this is a completely different story when we explore individuals in the 60s or in the 70s. We need to take into account these differences for sure when we are evaluating young individuals, especially women, and choose the technique that is going to detect the disease and not missing disease, because this is a loss of opportunity.
Great.
Thank you.
So I think the last question we'll ask to both, because I think it's a provocative question from our audience, but if you take the group that has a CAC of 0, but we see evidence of atherosclerosis in either the femoral bed or the carotid bed, what should we do with that? Should we be more aggressive with that patient, and how would you handle that in your practice?
Well, maybe I can start and Beatriz can also, because I know she has also a great insight into this. So I think there has been a great step forward in the clinical practice guidelines, especially from the European Society of Cardiology. In the recent update for dyslipidemias, treatment for dyslipidemias, having any plaque in carotid or femoral arteries directly assigns this patient or this subject into the high risk category. So eventually this should be enough in order to start any lipid lowering therapy or very tight blood pressure control. It is true that these ESC guidelines, they say that eventually significant atherosclerosis is what matters, And this typically is when the atherosclerosis generates an obstruction of more than 50%, which is not what we are talking about. So in that sense, even though there is a great step forward from the ESC guidance, still there is some uncertainty in what to do with subjects who have atherosclerosis, but this is not generating any significant obstruction. But we think that, yeah, in any case, this is enough in order to put the patient or the subject into a high-risk category. And for the American guidelines, and also they have released a very recent update or a full guideline for dyslipidemia, they are more CACs-based, even though they are quoting also peripheral atherosclerosis as a high-risk feature. But then when it comes to treatment decision, they are focused on CACs. And we think that this is a more conservative approach, which is fair, especially taking into account what is the current state of the art related to the association with hard endpoints. But as a summary, we believe that eventually having a subject in which there is some uncertainty whether to start or not lipid-lowering therapies or blood pressure control, as if you can identify and they have atherosclerosis in the peripheral arteries, even in the absence of calcification, this should be enough in order to put them in treatment.
Yes, what do you think?
Well, yeah, I completely agree with Borja. But also just to the other parties went to monitor these 0 patients, no? And I think we should monitor them preferably with the ultrasound because calcium always goes late. So if you want to detect early when these patients become a high-risk patient, I will recommend always to use ultrasound instead of wait for calcification to be detected.
Well, thank you guys both for joining us and giving these excellent presentations. I think we're out of questions from the audience, so we'll now allow our audience to go for a break, and we'll plan to meet back here in 5 minutes, so around 11:45.
Thank you. Thank you much.
Thank you very much.
Thank you.
Bye.
Thank you.
Bye-bye.
You guys are great.
Thank you.
Welcome back, and thank you for hanging in here with us on a Saturday morning. We have one more exciting session for you to conclude today's program, and it's really about cardiometabolic imaging, obesity, MASLD, and body composition. A few reminders before I highlight this session, but I would ask everyone to please complete our survey at the end of this program. That gives us really useful information as we're determining what other educational initiatives to offer. And then if you want to watch these sessions recorded or you missed a few, those should be available live around May 1st on aspconline.org. So check there. So now for our final session, this is going to feature a lecture by Harold Bays from Monroe Biomedical Research discussing body composition imaging, muscle quality, sarcopenic obesity, and assessing cardiovascular risk in patients with obesity, which is an incredibly timely topic as we talk about new medical therapies. And then we're going to have Salvatore Carboni from Old Dominion University talking about diet and exercise management to improve outcomes after plaque and body composition imaging. And finally, Donna Ryan from Pennington Biomedical discussing obesity pharmacotherapy through the lens of imaging, body composition, visceral fat, and plaque analysis. Take it away, Dr. Bays.
Hello, my name is Dr. Harold Bays, Medical Director of the Louisville Metabolic and Atherosclerosis Research Center, located in Louisville, Kentucky. I am a endocrinologist, but also a clinical trialist. And one of the things that we do a lot within the context of our clinical trials, certainly recently, is evaluating our patients for body composition. And that's because we're doing so many of the obesity trials. So that's a topic I've been asked to cover is, what's the practicality of measuring body composition in our patients? These are my disclosures. What are our learning objectives? Well, we're going to talk about, again, body composition and how that relates to cardiovascular disease risks. And what about this change in lean body mass that we hear so much about when we have people on weight reduction therapies? And then finally, get into the real practicality of what's going on with imaging when it comes to patients with the obesity. And again, this is intended to be a very practical discussion of imaging as it pertains to not just the clinical management of patients, but also the research management of our patients. All right, so let's talk about imaging from a cardiovascular testing standpoint in our patients with obesity. A lot of things to know. The first thing is a lot of these standard risk calculators may underestimate cardiovascular disease risk in our patients with obesity. Now, there are some body mass index inclusive tools like Prevent and Q-Risk. There are also issues, as I'm sure you're aware, that when you have patients with the obesity, you got to be very careful about blood pressure cuffs. Make sure you have the right size cuffs because that can result in pseudohypertension. Be careful about assessing electrocardiograms. I mean, I do multiple electrocardiograms interpretations every day, and a sizable number of our patients have a false reading of, say, inferior myocardial infarction or some other abnormalities. Electrocardiogram abnormalities, very common in patients with obesity. Then, of course, other cardiac diagnostic testing can have challenges in patients with obesity. Echocardiogram may be poor quality. Some of the other imaging procedures require enhancing agents, increasing doses. When there's going to be coronary catheterization, there may be a need for different approaches and such. So again, a lot going on when we start doing imaging tests in our patients with the obesity. So let's talk about body composition. What do we do? In our research site, again, it's a research facility, but we also do this in a lot of private patients. We predominantly use dual X-ray absorptiometry. I'll talk more about that later, but that's basically what we use. Now, you may hear other people doing calipers, but for anybody that's done calipers, we know that they're really not optimal, and it's very much user dependent, and there can be a wide variance in results depending on the person who's performing the test. A lot of folks use bioelectrical impedance, and the accuracy is variable depending upon which particular bioelectrical impedance device that you have. And then there's air displacement, plasmography, and underwater weighing, and CT and MRI, and these types of things. But again, if I had to pick the two imaging techniques, at least around this area, that we use most often, it would be DEXA and bioelectrical impedance. But as I said, I know some other people do some of these other testings as well. What does it mean? Well, the first thing to know is there's all different types of cutoff points for these classifications. This is one from the Obesity Medicine Association. And, basically what we're talking about is that percent body fat is diagnostic. And what does that mean? That means if you have an increase in body mass index, you don't know if it's an increase in muscle, and you don't know if it's an increase in fat. You just know that relative to their height, this is what their weight is, and you get this calculation. So we need to be very cautious when we start solely relying on body mass index and assessing our patients with the obesity. As opposed to diagnostic, now we have prognostic measures, and prognostic measures would be measuring that visceral fat and android fat, because as we all know, an increase in visceral adiposity or increase in android fat is associated with an increase in cardiometabolic disease as well as cardiac disease. This becomes important in certain patient populations. Let's just start in our patients or Black individuals. It is common that we find maybe an increase in muscle mass, and it is common that we often see a decrease in visceral adiposity compared to other races and such. So again, need to be cautious about just using body mass index, and really need to be cautious about simply relying on waist circumference. I mean, waist circumference has its value. Increase in waist circumference associated with cardiometabolic risk. All those are true, but if you have a patient who has an increase in waist circumference, that doesn't necessarily mean they have a marked increase in visceral adiposity. You need to be very careful. So here's another example. What about females? Females often have a decrease in visceral adiposity. So we see females all the time that come in and waist circumference is increased, but maybe only have a modest increase in visceral adiposity. Flip side would be, what about patients of Asian descent? There, the waist circumference may not be so large, but the amount of visceral fat may be increased. So again, all trying to bring forth the point that it's not just body mass index, that there's value to body composition analysis. All right, what about muscle? Well, look, with rare exception, whenever you have weight reduction, that's going to be accompanied by a reduction in lean body mass. I can count on one hand how many of our private patients have come in that have had substantial weight reduction who've been able to maintain their muscle mass or maybe increase it. But that requires extraordinary effort, and that should not be the expectation. The expectation is somewhere around 20, 30, 40, maybe even 50% of the weight reduction being that of lean body mass. Well, how do we assess lean body mass? Well, again, here at our research site, we have a DEXA. So lean body mass we do with DEXA. That's how we measure it. But when we really want to get accurate assessment of skeletal muscle, then we send people off to an off-site facility where we do magnetic resonance imaging. Don't do a lot of CTs for purpose of assessing skeletal muscle, but we certainly do magnetic resonance imaging. All right, so you might ask yourself, well, that tells us about muscle mass, but what about muscle function? I mean, is there any kind of correlation there? Well, I got to tell you, folks, it's really hard to tether out this relationship between muscle mass and muscle function. Not as easy as you might think. First thing is, muscle biopsy is going to help very much. I mean, I'm not a pathologist, but I've talked to people who do this, and they say muscle biopsy is really not particularly helpful when you're trying to assess the relationship between muscle mass, muscle function. So what we do instead is we do things like step devices or motion devices or stair devices. We can do walking distance testing, sitting to standing testing, and then dynamometer devices. And what are we talking about? Well, here's our DEXA. This is literally our DEXA that is located within our research site. So the patient lies flat and we perform the test. There's an example of one of our bioelectrical impedance devices. Here's step devices. I think many of us have these wrapped around the wrist and measure the amount of steps often per day. Here's a motion device around the waist, and it just measures the degree of motion that a person has throughout the day. So that is thought to be a assessment of muscle functionality. And here we have stair devices. And you can see here at the very bottom, there's a mat. And then a patient will go up 1, 2, 3, 4, 5, 6, 7, 8 steps, and then step on the other mat that, has electrodes and such that monitors. And it's, how fast does it take to go up these steps to get to the other mat, from one mat to the other mat? And then that's the stair step assessment. Here's a 6-minute walking distance. What you do is you map out how far or the distance in a 6-minute walk. And so we measure the distance as a patient walks for 6 minutes. And again, very practical, very meaningful from a clinical standpoint, assessment of muscle functionality. And you wouldn't think that a chair would be that complicated. But folks, this is our 30-second chair test, sitting to standing. And as you might imagine, you've got to have the right chair. It's got to be sturdy. It's got to have no handles on the sides. It's got to have good, back and such. And it's got to have the right width and all of these types of things. So a lot of thought goes in to something as seemingly as simple as a chair. But these are the types of devices and such that we use every day in assessment of our patients with the obesity. And here's a dynamometer. That's one of the advantages here is whenever there is weight reduction, there's going to be an improvement in global muscle function. And so just simply by having weight reduction alone, going to be an improvement in a 6-minute walking test, going to be an improvement in the sitting to standing, there's going to be an improvement in a lot of these large muscle tests simply because you have less weight, less resistance. And so one of the advantages of a dynamometer, it's, grip strength, is, that's testing some of the smaller muscles and such, and maybe not so dependent on the larger muscle groups, and maybe there's some advantages to there. Now, I know that, at least in my world and in the world of clinical research, there's always this obsession with seeing how it is that if you have a particular therapy with a particular mechanism of action for which you've tested the hypothesis of that mechanism, once you've established that, then again, there's this gravitation towards figuring out how it is that the drug works for reasons other than the way you tested it. All right, we've been through that with the statins. We developed the statins, it was for cholesterol lowering. Then people tried to say, well, the real reason statins work doesn't have anything to do with their cholesterol lowering. That's an entirely different story, different presentation. But here, when we talk about obesity and weight reduction, there are folks that are of the belief that much of the improvement that people get, say, for example, in osteoarthritis and such, has to do with anti-inflammatory effects of the GLP-1 receptor agonist, reduction in pain, these types of things. Well, as it turns out, we tested it as best that we could. And we published this, you can see here, New England Journal of Medicine. And, basically what we found is that improvements in a 6-minute walk distance were not associated with reduction in pain score, but in fact, most correlated with weight reduction. Now you might say, well, that's sort of counterintuitive, and I'm just not sure that it is. Admittedly, when we first saw the results, we were maybe a little confused, but if you think about it, if a person has weight reduction and now they have greater mobility, then maybe they push themselves a little bit more. Maybe they have an opportunity to use those muscles in a way they did not before. And as a result, maybe there's an increased susceptibility to pain. So decrease in pain because you're decreasing the body fat, but maybe an increase in pain in some individuals, increase in pain for some individuals because you're having greater mobility. And the essential point that I'm making is this. Just sometimes I think it's important not to dismiss the main effect that we anticipate is occurring with these drugs that we develop. And maybe it's okay to look at a drug that is a anti-obesity drug, a drug that is intended to result in weight reduction, improve the lives of our patients. Maybe it's okay to say, what are the benefits of that weight reduction, and how can we employ imaging testing and such in order to assess the degree that that reduction in body weight improves muscle function. So overall, what I would say is, in this presentation, this brief presentation, I hope you've gotten a sense about how it is that body composition imaging, including the percent body fat, visceral fat, lean fat, really informs us with regard to diagnosis and cardiovascular disease risk. These tests, as you see them, some of them look sort of simple and such, but I mean, that's the point. It's the overall functionality, and it's the simplicity of the ability to move and have movement and these types of things that I think is a really good test that gives us a lot of information, a lot of clinical information as to the patient status, not just from a cardiovascular risk standpoint, but from a quality of life standpoint. And we've talked about how it is that there's this relationship between weight reduction and changes in lean body mass that can be mitigated somewhat with adequate nutrition, protein intake, but also maintaining that resistance training. But don't get me wrong, the expectation is there's going to be some reduction in lean mass, even with resistance training. So we need to give our patients some grace here. And yes, we need to recommend these things, but it should not really be the expectation. And finally, hopefully you've gotten a sense of some of the practical tools that we use every day in order to assess muscle functionality in our patients who we treat for the obesity. And with that, I want to thank you for your attention, and thank you for attending this imaging symposium for the American Society of Preventive Cardiology.
Good afternoon, everyone. My name is Salvatore Carbone, and I'm an associate professor and director of the nutrition program at Old Dominion University in Norfolk, Virginia. I'm extremely excited to be here today and to talk about such an important and timely topic, which is the role of diet and exercise to improve outcomes in patients at elevated cardiovascular risk. I don't have any disclosure. And these are the two main learning objectives for today, and specifically to identify effective dietary interventions and exercise training intervention to prevent cardiovascular disease in individuals at risk with an established cardiovascular disease. And I wanted to start with a very important question, which is the following. And does the quality of calories make a difference on cardiovascular outcomes even in absence of energy restriction-induced weight loss? Essentially, does the quality of food that we eat play a role in influencing cardiovascular outcomes, independent of whether an individual is gaining or losing weight? And until only a few years ago, we didn't have as much evidence deriving from randomized control trial that could support whether diet quality was really critical. And to answer this question, I think there are three studies that have really changed the way we approach nutrition over the years, at least in my opinion. The first one is the WHI, the Women's Health Initiative study. And one of the randomized trials within the WHI was a dietary intervention with the idea that, with the hypothesis that a low-fat diet could reduce cardiovascular events. And in fact, at that time, this dietary pattern, so low-fat diet, was being recommended by major societies, including the American Heart Association, to reduce risk for cardiovascular disease. And as you can see here, this was a very large study. And at the end of the study, the patients did achieve a low-fat diet, although a little bit higher than what the investigators were planning to achieve. And they did reduce saturated fatty acid intake from 12% to 9%. However, when they look at the primary endpoint for the study, the low-fat diet did not result in a reduction in cardiovascular events, specifically the composite of MI, coronary heart disease, death, or revascularization, suggesting that a low-fat diet, at least in this very population, was not effective in reducing cardiovascular events. On the right, you can see the PREDIMET study, which is a primary prevention study, and then the Cardiometabolic study, which is more recent study looking at secondary prevention, so patients with an established ASCVD, both done in Spain. The PREDIMET was a multi-center trial, the Cardiometabolic a single-center trial. And you can see that here, there was actually an increased consumption of dietary fats compared to what we've seen in the WHI. However, the increase in dietary fats here was deriving from unsaturated fatty acids or healthy fats. And in the PREDIMET, we had 3 arms. It was a 3-arm study. It was a low-fat diet as a control, which again, at the time was being recommended by major societies. A Mediterranean diet supplemented with extra virgin olive oil, where participants were receiving 1 liter of extra virgin olive oil per week to be used and shared with their entire household. And then a 3rd arm, which was a Mediterranean diet counseling in addition to daily mixed nuts, which included at least a handful of 30 grams of nuts per day, which was including hazelnut, walnuts, and almonds. The Cardiometabolic was very similar. However, it was only a 2-arm study where the low-fat diet was being compared to a Mediterranean diet supplemented with extra virgin olive oil. And as you can see here, there were no caloric restrictions, and in fact, there was no weight loss at the end of the study. However, when they look at cardiovascular endpoints, you can see that both in the PREDIMET and in the Cardiometabolic, there was a dramatic, statistically significant reduction in the composite primary endpoint, which included cardiovascular events, suggesting that really independent of diet, independent of weight loss, a high healthy fat diet or a Mediterranean diet rich in unsaturated fat could be effective in reducing cardiovascular events, as shown in these 2 major randomized control trials. When you looked at the food that was particularly increased in both the PREDIMET and the Cardiometabolic study, you can see a dramatic increase in extra virgin olive oil. There was, by the end of the study, about 4 to 5 servings of extra virgin olive oil being consumed per day. But we have to keep in mind that these were studies done in Spain, where the baseline consumption of olive oil is already quite high compared to the United States. And to these days, we do not have a PREDIMET-like or a Cardiometabolic-like study in the US. And so this is an urgent need that I think we should try to fill in the future with a multi-center randomized trial. Mechanistically, I think it's very interesting to see that the PREDIMET, in particular the Mediterranean diet, was listed among the anti-inflammatory therapies in this 2025 ACC scientific statement for inflammation and cardiovascular disease. And it is true that across different studies, Mediterranean diet has been associated with lower level of systemic low-grade inflammation measured with either C-reactive protein or interleukin-6. However, the effect on the anti-inflammatory effect are not as powerful as you would see with other anti-inflammatory medication. As an example, we see here canakinumab, which is an IL-1 beta monoclonal antibody. Inspired by this work, PREDIMET and Cardiometabolic over the years, we have been particularly interested in investigating the effect of nutrition, particularly dietary fats, in patients with obesity-related heart failure with preserved ejection fraction or HFpEF. And so we've done a number of studies over the years. Starting on the left, we started with a cross-sectional analysis of patients with obesity and HFpEF and that underwent a validated dietary assessment and a maximal cardiopulmonary exercise testing with gas exchange analysis to measure VO2 peak, as well as body composition with BIA and cardiac function. And we found that patients who were consuming the larger amount of this unsaturated fatty acid-rich food, like canola oil, olive oil, nuts, avocado, had a more favorable exercise capacity, body composition, and diastolic function, which is one of the hallmarks of HFpEF. And then in a mouse model, we've shown that when we feed mice with diets that have the same amount of total calories, same amount of total fat, when we just modify the quality of the fat, the mice that were fed with the high UFA diet, so the high unsaturated fatty acid diet, did not gain as much weight and their cardiac function was preserved compared to a Western diet fed mouse that actually developed weight gain and obesity and severe diastolic dysfunction, as well as interstitial myocardial fibrosis. And this allowed us to do two clinical trials. The UFA Preserve 1 was a small single-arm study, and the UFA Preserve 2, a little larger, still relatively small, 30 patients, was a randomized controlled crossover study. And in both studies, we were emphasizing the consumption of food rich in healthy fat, like extra virgin olive oil, canola oil, unsalted or lightly salted, mixed dried tree nuts and peanuts. And this approach was inspired by the Predimed, where they did not have caloric restriction, and that's what we did, except we tried to modify some food to make it more realistic for our population here in the US. And by the end of the study, what we found on the left, we found that patients were able to change their diet within 12 weeks. So they were consuming more food rich in unsaturated fatty acid. And interestingly, we also saw an increase in monounsaturated fatty acids, such as oleic acid, in the blood, in the plasma, suggesting that patients were actually not only eating that food, they were able to digest it, absorb it, and we were able to measure in the plasma as an objective measure of dietary consumption. And we replicated this finding also in the UFA Preserve 2, which we recently published in Circulation Heart Failure. And in a sub-study, in a subgroup of patients in the UFA Preserve 2, we did also cardiopulmonary exercise testing and shown that there was a positive correlation between the changes in plasma UFA, suggesting greater consumption of food rich in UFA, and VO2 peak changes. And now we're hoping to design a future study larger, powered enough to look at clinical outcomes. If healthy dietary fats can help reducing cardiovascular risk and hopefully even in heart failure show some beneficial effects, an unhealthy dietary fat consumption, especially when consuming large amounts, could have actually a dramatic negative effect on cardiometabolic risk. This is a case series of patients undergoing a ketogenic diet. And you can see here is that when they start their ketogenic diet, there's a dramatic increase in LDL cholesterol, then returns back to baseline after the diet is interrupted. And on the right here, this is a randomized controlled feeding trial, crossover. Controlled feeding meaning that the meals were being prepared and provided to the participants by the study team. So this was really a very strong proof of concept. And there was a randomized control trial of 24 women where the subjects were following 4 weeks of a ketogenic diet, followed by a 4-week of control diet. And as you can see here, by the end of the 4 weeks, there was a mean increase of 70 milligrams deciliter for LDL cholesterol in these participants. And interestingly, the ketogenic diet increased LDL cholesterol in every woman. So, and in this case, suggesting there were no non-responders to an increase in LDL cholesterol following a ketogenic diet. And so really currently, we do not have the evidence to support the use of a ketogenic diet to reduce cardiovascular risk. I personally recommend against it outside of clinical trial, considering the negative effects on lipids, unless lipids are being managed very, very closely by the cardiologist. Another dietary pattern, in addition to the Mediterranean diet, that has been studied quite a bit over the years, is the DASH diet. The DASH diet, we know very well, is a dietary pattern rich in fruits and vegetables, fat-free or low-fat dairy, fish, lean meats, nuts and seeds, beans, legumes in general, and vegetable oil, and limit the consumption of fatty meats, full-fat dairy, sugar-sweetened beverages, sweet and sodium intake. It emphasizes the consumption of potassium and limiting the consumption of sodium. And as you can see here, the results from the original DASH diet study, you can see that pretty much every group of patients responds to a DASH diet by, as shown in a reduction in systolic and diastolic blood pressure. However, over the years, DASH diet has been studied particularly with regards to blood pressure control, but it hasn't been much work on looking at plaque regression in patients with atherosclerotic cardiovascular disease. Which is why the DISCO-CT trial, dietary intervention to stop coronary atherosclerosis in computed tomography study, was extremely important. This was a study where patients were being randomized to either a DASH diet following counseling sessions with the registered dietitians, and also encouraged to increase their daily physical activity. To be included in the study, a patient had to have a coronary atherosclerosis lesion confirmed by coronary CTA, defined as a maximal luminal stenosis of less than 70% in at least 2 coronary artery segments, which was at the time according to ACC AHA classification. After 67 weeks, the investigators look at the changes in percent atheroma, volume, and plaque components. And you can see here that in the DISCO intervention, so the DASH diet intervention, there was a significant reduction in the non-calcified plaque compared to the control, while the other component that you can see here did not reach statistical significance at the time group interaction. And so overall, although the difference was relatively small, the author suggested that perhaps this intensive diet and lifestyle intervention could slow the progression of coronary atherosclerosis and ultimately reduce the volume on uncalcified plaque. Although this is not really a study that looked at atherosclerosis per se, in fact, this was still a study looking at targeting blood pressure reduction, I think it's an extremely important one, the sole substitute in stroke study, because this was a very large cluster randomized trial where entire villages in China were being randomized to receive either regular salt or salt substitute, which will contain 75% sodium chloride and 25% potassium chloride, where patients were being encouraged to consume that for the entire household. By the end of the study, there was a small yet statistically significant reduction in systolic blood pressure by a little over 3 millimeters of mercury in systolic blood pressure. But most importantly, there was a dramatic benefit on clinical endpoints. There was a reduction in stroke, major adverse cardiovascular events, death from any cause, without an increased risk of hyperkalemia, which has been historically the concern of using potassium-based salt substitute. Based on this study and others that have been published after this 2021 paper, last year with the newer hypertension guidelines actually started recommending potassium-based salt substitutes to prevent or treat elevated blood pressure and hypertension, particularly in those who have an elevated consumption of sodium in their diet. All of the studies I've shown you so far have been outpatient studies. And so I really want to emphasize the importance of referring your patients to registered dietitian as an outpatient, but particularly when they're admitted to the hospital. And this is because, for instance, in the F4 trial, this was a study done in Europe, patients who were admitted to the hospital in medicine were randomized to an intensive nutrition support led by registered dietitian or standard of care. And this intensive nutrition support in patients with a moderate to elevated risk for malnutrition included oral nutrition, enteral, and parenteral nutrition, which was very quickly escalated by the registered dietitian in collaboration with the clinician, with the physician. And as you can see here, there was a dramatic reduction in 30-day mortality post discharge in patients who were randomized to the dietitian-led nutrition support. Similarly, at time of discharge, this was also another heart failure study. At time of discharge from an hospitalization for heart failure, patients who were randomized to a comprehensive dietary intervention led again by a registered dietitian had a dramatic benefit in terms of a reduction in all-cause mortality with a very low number needed to treat without significant interaction for LVEF, suggesting that all patients with heart failure benefit from this intervention. So this is just to further encourage all of us to really keep referring our patients to registered dietitian, because they allow to conduct very individualized and tailored dietary interventions. With regards to exercise training, as you can see here, this was an updated meta-analysis published in the European Heart Journal just a few years ago, clearly showing that exercise, particularly cardiac rehab programs, improve health-related quality of life. They're cost-effective. They reduce the risk for cardiovascular mortality, MI, and hospitalization. However, the data on all-cause mortality were not statistically significant. And so overall, cardiac rehab should be recommended, but there were two studies that were somewhat showing different results. The first one is the rehabilitation after myocardial infarction trial on the left, and on the right was the more recent pipeline study. You can see here that in the first study, there were no significant difference on the cardiac rehabilitation program. On the right, there was a 43% relative risk reduction for the cumulative incidence of the primary endpoint in the cardiac rehab group, suggesting that this intervention might have they had different effects. And one of the reasons was the population. On the left, that was a relatively low risk, younger post-MI patients. On the right, in the pipeline trial, patients were older with a median age of 80 years, and they had to have a documented impaired physical performance to be enrolled in the study. Moreover, the pipeline had a very unique study design because it delivered a structured, tailored, multi-domain intervention that combined cardiovascular risk factor management, individualized dietary counseling, and a validated exercise program, which included balance, strength exercise, as well as moderate walking. Another important study that I think has really had made an impact in the field of nutrition and lifestyle intervention in general is the Look Ahead trial. The Look Ahead was a randomized trial that investigated the effect of intensive lifestyle intervention in patients with type 2 diabetes. And over the years, you can see that there was a significant improvement in cardiometabolic risk factors as well. However, the major changes were seen particularly after the first year. But at the end of the study, when investigators look at the primary endpoint, which included cardiovascular events, there was no significant difference with the intervention compared to the standard of care, suggesting, at least in this case, that the lifestyle intervention was not enough to really achieve, to really reach a significant reduction in cardiovascular events. However, the Look Ahead investigators performed a post-hoc analysis, really trying to determine whether maybe one of the reasons that the study was not positive was that patients just did not lose enough weight that could justify, that could explain the reduction in cardiovascular events. And in fact, it is this analysis, which I think was very important, showing that patients who lost at least 10% of body weight in the first year of intervention, they actually presented a lower risk for heart cardiovascular events, which is why currently we still recommend this 10% threshold with our patients. However, we need to keep that in mind that this is the results of a post-hoc analysis of a negative trial. So we need to, I still personally tend to emphasize the effects of diet quality based on the PREDIM and the CardioPrev studies rather than just focusing on weight loss. And so in conclusion, in a perfect world, I think we've heard also other speakers today talking about the importance of body composition and body composition phenotyping. In a perfect world, all our patients will be seen by a nutrition specialist that is able to assess the body composition phenotype and whether patients have malnutrition, sarcopenia, sarcopenic obesity, or maybe a combination of those, like malnutrition that can be present also in patients with obesity. The first step is to really individualize nutrition and exercise needs. And then once we have identified those needs, we optimize the dietary pattern toward a DASH diet or a Mediterranean diet, since these two seem to be the ones with stronger data. And then more recently, we also discussed the role of nutrition and exercise training in the setting of incretin mimetic therapy, such as GLP-1 receptor agonist and single or dual agonist, really emphasizing the importance of nutrition, interdisciplinary approach to lifestyle interventions to ultimately help in reducing the cardiovascular risk of our patients. And with that, I want to thank all of you for your attention, and I would be happy to take any question during the Q&A session.
Hello, I am Dr. Donna Ryan, and I'm Professor Emerita at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. These are my disclosures. And what I want to talk to you about today in 10 minutes is trends that are happening in body composition imaging in weight reduction, both in research and in clinical practice. And I want to finish up with where I think we're going to head, both in the research direction and in the clinical practice direction. But before we begin, let's get straight on our nomenclature. So we're mostly going to be talking about DEXA results. And when we do DEXA, we determine body mass and fat mass. And so sometimes you'll see a report of fat mass and fat-free mass. Now, DEXA is very accurate at measuring bone mineral mass. So we have the option of subtracting out the bone mineral mass and have a 3-compartment model of fat mass, lean soft tissue or lean mass, and bone mineral mass. So the important thing to recognize is that fat-free mass is not the exact same thing as lean mass or lean soft tissue mass. Okay, when we lose weight, it is inevitable that we will lose both fat and lean. The reason for this is that at the reduced body size, you do not need the same amount of muscle, bone, and organ size to support the reduced body size. With weight loss, generally, what we have seen in the past is about 75% of the weight that's lost is fat and about 25% of the weight that's lost is lean. And most of that lean loss is muscle loss. Okay, so the goal of weight loss is, of course, the reduction of excess abnormal body fat. So we want to remove both visceral body fat, ectopic body fat, and some subcutaneous body fat. And when we lose that ectopic body fat from muscle, it improves muscle function. But what we don't want to do is to reduce too much muscle and bone in individuals who begin with low levels of muscle mass, individuals with sarcopenic obesity. So for a long time, we've all believed in this Forbes rule, and that is the quarter fat-free mass rule. And that is that of weight that is lost, 25% ought to be fat-free mass. And this is what is accounted for in that reduction in body size. So of course there was concern when our 2 GLP-1 receptor agonists were reported out. The FDA requires them to do a body composition study. And so their DEXA results showed that with step 1, and that's semaglutide, the reduction in lean mass was 10.1%. With SURMOUNT, which is tirzepatide, the reduction in lean mass was 7.9%. At the same time, there's going to be a reduction in age-related muscle loss of about 0.5% per year. So just to give you an idea. So what the concern was with semaglutide in step 1, that lean loss was 6.9 kilograms. It was about 40% of the weight that was lost. And in tirzepatide, it was 6 kilograms, about 26% of the weight that was lost. So there was some concern about this. I think that subsequently, semaglutide has been rehabilitated in studies such as this, the SIMILEAN study. In this study, DEXA, BIA, and muscle function were all measured. And it did show that there was a great reduction in fat mass, including visceral adipose tissue. But there was not an excessive reduction in lean mass, including appendicular skeletal muscle. They also measured a measure of muscle function, hand grip strength, and that actually improved. So this and other studies have rehabilitated semaglutide's reputation to some extent, at least in a population that is younger and has obesity. You know, individuals with obesity start with an elevated muscle mass due to the weight bearing. And indeed, obesity does tend to protect from osteoporosis. But subsequently, there have been studies of these myostatin activin pathway inhibitors alongside and along with semaglutide and tirzepatide. So the idea here is that myostatin inhibition will increase muscle mass. And it's thought that when we use these drugs in individuals who are older, who have less lean mass, that we can ameliorate or maybe improve muscle mass in these individuals. So in these studies, it was shown that the percent weight loss that was fat ranged from 72 to 67%, which means that the Forbes rule would be about 28 to 33% of the weight that was lost would be due to lean loss, and that would be acceptable. There's an emerging consensus around the GLP-1 and other NUSH-based therapies that the weight loss is mediated by these drugs is adaptive, that the lean loss is adaptive. It is not maladaptive. So that is important. But it's still going to be a very important area for research. And the tools we're going to use there mostly are MRI and CT. Of course, the problem with CT is it's very, very accurate, but it does have radiation exposure. MRI is equally accurate in terms of body composition assessments, but it doesn't have an automated assessment tool built into it. The software is not there yet. And so it requires an individual to go in and do calculations. That problem will be solved in the next few years, and we can expect to see MRI being used more and more in body composition analysis in these studies. Look, the gold standard for muscle change is D3 chromium dilution, but that's only available in a few labs. It requires a very special kind of mass spectrometer. You can also expect to see more interest, not just in muscle loss, but also with bone loss. And that is because these medications are going to be used in an older population. They have disease-modifying characteristics, and we'll want to know in that population, are there ways that we can prevent the body composition getting worse and can actually improve body composition in those cases. So what about the clinic? In the clinic, we need better tools than we currently have. We're still in the Stone Age. We've got a scale and we've got a tape measure in the clinic. We need to be able to tell to track weight loss in those special populations I was talking about. And we also need a better way to determine excess abnormal body fat. There's a movement away from using BMI alone. And as you know, we have a hard time getting waist circumference measured in the clinic. So there's a movement away for that, and we need better tools to help us actually identify individuals who have excess abnormal body fat, especially visceral adiposity. So this just gives you an idea of what's going on with weight and body composition across the lifespan. So here I'm tracking BMI from age 10 to 100 for men and women in the different races. So yeah, there's some changes, but the general trajectory is the same. There's weight gain up until the 60s when weight tends to stabilize and then is decreased. What's going on there in your 70s and 80s is that there's the endocrine involution of aging, and there's loss of lean mass, of muscle and bone. And so we're all familiar with that. And that is why it is important that we be careful about weight loss in these older individuals. Okay, here's our tools for the clinic. Yes, I have been working in this field for about 35 years and preaching the value of measuring waist circumference, but it is still rarely, if ever, measured in the clinic. We need better tools. And here's some candidates. So air displacement plethysmography, that's the BOD pod you see on the left. And what it does is it measures your volume by the displacement of air in that pod. And so if you know the volume and you know the weight, you know the percent fat, right? And then I'm showing you the DEXA. And I think we can expect to see DEXA used more and more in the clinic. You know, it really does have low dose X-ray exposure, and I think it is going to be perceived as more and more acceptable to be used in the clinic. But we also have bioimpedance analysis. What that does is it sends an electrical current through your body. And you know, the principle there is resistance. So lean tissue has more electrolytes, and it has less resistance to this electrical current, where fat has greater resistance. And so if you know the weight and you know the resistance, you can by formula calculate the percent body fat. So that's what's going on with bioimpedance. But the one I'm most hopeful about is this 3D digital anthropometry. And what that does is it uses cameras to take pictures of you and then construct a 3D avatar. And that 3D avatar can be measured. And if you know the weight and you know the volume of the avatar, you can know the percent fat. We actually think that the waist circumference measurement on this is more accurate than the tape measure that we're trying to use in clinic. Okay, just to show you that 3D avatar, here's a patient that we're following at Pennington. She's on a GLP-1, and she started out in September weighing 104 kilograms, and March 2nd, her weight was down to 85 kilograms. Her waist circumference had decreased from 117.6 centimeters to 103.3 centimeters. So what this, of course, allows us to do is follow this patient from a BMI of 38 to 35 to 31.2. So we think this technology is, and this was measured with a smartphone. A smartphone or an iPad is all you need to get this measurement. Okay, so the principle there is that the avatar can be measured, the volume can be determined, and from that you can determine the percent body fat. But you can also get all of these other measurements that we think are very helpful. So I put on here the website for this. You can go to it for free, me360.com, METHREESIXTY.com. You can go home, it's free. You can try this on yourself. But there's a study underway. It's sponsored by an independent body, the Foundation for the National Institutes of Health, and it's evaluating both BIA and 3D digital anthropometry as alternatives to DEXA in the clinic. So I'm hopeful that this is going to make its way into our medical clinics. Why shouldn't it? It's something that's inexpensive, it's less intrusive really than measuring the waist circumference, and it gives us a lot of really good clinical information, which we need. So going forward, what I expect to see is this is a hot topic. There's going to be a continued focus on advanced imaging in the research arena, and we're going to see more and more uses of DEXA, digital anthropometry, and BIA in our clinics. So I want to thank you very much for your attention. I enjoyed putting this together for you. Thanks.
Hello, and we are back for our last question and answer session of the morning. So thank those of you who've stuck around with us, and for those of you who are watching this recorded, that's great too. So I think this session's been really great. We talk a lot about body composition, but we don't think as much about how we measure it, what tools are available, or sort of what we do with those changes. So Dr. Bays, I'm going to ask you first. You talked to us a lot about different ways to measure body composition. What do you recommend in clinical practice? And is that covered? And if it's not covered by insurers, do you have tips on how someone could get that information?
Sure. Well, first off, thank you so much for this program. It's just been fabulous. I really appreciated comments by the other speakers and such. And answer your question is, I think it's very much location dependent. For example, there's some places where underwater weighing may be readily available, or some places where you can get bod pods and those types of things. I can only speak for here in Louisville, Kentucky, which is where I'm from. We have a DEXA on site, so we routinely perform DEXAs on private patients and such. So what would I recommend? I would recommend DEXA. But there's plenty of other options available, whether it be for example, bioelectrical impedance is really taken off. The only thing I would caution there is, just like anything else in life, depends on the machine. Depends on the quality of the machine. Is it foot to foot? Is it foot to hand? Is it what quality machine you're getting, and then what information are you wanting to get from the device? If all you're wanting is a % body fat and whatever, or a change in % body fat, some argue you could just do calipers. Now you'd want to do 3-point calipers and make sure you're trained on how to do it. But if your goals to say, I'm not just looking for diagnostic, which is % body fat, but I really want to know prognostic, there you're going to want for visceral adiposity. And yet even then, while DEXA is pretty good at that, not all DEXA machines do the visceral adiposity. So what I'm trying to say is, depends upon your location, make sure the machine's going to do what your goals, what you're setting the goals to be, and make sure it is that you know what exactly that you're looking for. And I think you can find a thrifty, as far as insurance coverage. No, I don't know that insurance covers it. You have to be careful. The DEXA's insurance covered if it's for bone mineral density, not necessarily body composition. You need to be careful. Some people will do DEXA, but won't do it for body composition. But to very much directly answer your question, we charge $125 for the first DEXA and then $90 for each subsequent DEXA, to give you a ballpark figure. And I think that's pretty mainstream, at least for DEXAs and such.
Excellent. Thank you. That's very helpful.
Thank you so much. Yes, I think it's not the common thing in many institutions, I think, to have this. So hopefully more people start to offer that. I know in New York it's hard to get a DEXA for that indication. So thank you very much. We have another question here for Dr. Carbone. Here it says you gave us a lot of great information, and I agree. And the question here is, what diet do you recommend overall to reduce cardiovascular risk in primary prevention? And I would add to this is if there's any diet in particular to change this body composition. I've asked before about the role of protein and these high protein diets. So I know your thoughts, but maybe you could talk about that. And finding plaque, or finding if someone comes and tells you that they had a calcium score that was high, how does this change your advice?
Yeah, that is a great question. Like Dr. Bays said, first of all, thanks again for having me as part of this incredible conference and in this really beautiful session. So to answer the first question about primary prevention, I think we have to, that's where we have to focus on individualizing our intervention. Overall, in terms of data from randomized control trial, Mediterranean diet data from the Predimit done in Spain suggests that really that is the intervention associated with the greatest reduction in cardiovascular risk. There are also some mechanistic sub-analysis of the Predimed and the CardioPrev, where there are also some changes in the actual anatomy of coronary arteries following a Mediterranean diet. And so that would probably be the strongest. However, we are in the US, and so whether we could really replicate the same dietary intervention in our patients, we still don't know. What we personally do in our practice, we take some components of the Mediterranean diet and we try to see whether those are feasible and achievable in our patients. For instance, olive oil, nuts, those are just some example, avocados, and we try to, based on the diet of our patients, individualize and see how we can incorporate those food in an individual diet. And then again, individualization is critical because if you have an individual who's still hypertensive, the data for blood pressure control with DASH diet and now with salt substitute, which are sodium chloride and potassium chloride, salt substitute are quite powerful on blood pressure reduction, but most importantly, like I showed earlier, on reduction of cardiovascular events. And then for the second question about GLP-1 or incretins in general and nutrition, that is a billion-dollar question. I think there's a lot of, there are some studies ongoing right now. Like Dr. Ryan was presented earlier, we are very concerned. We were particularly concerned about the lean mass loss, but the newer data from Semelian, for instance, are very reassuring, meaning that even if we're losing an absolute amount of lean tissue, we're still overall preserving muscle quality in terms of strength over lean tissue. And so the amount of protein that the average American consume, it's probably adequate. And so I don't think we should preemptively recommend protein supplementation in all our patients on incretin mimetic therapies. But ideally having a nutrition assessment where we can identify those patients who maybe are consuming a very little amount of protein and those might need a supplementation, but not in everybody.
That's great. Thank you so much.
Dr. Ryan, I'll address this next question with you, but we're using GLP-1 receptor agonists a lot more across, I think, all of our patient populations. But in cardiovascular disease, now we have the indication, and some of those patients are just in the overweight category, not even in the obese category. So does the changes you see in muscle mass do you think about those based on the patient, and do you recommend imaging, or what do you do? What's your recommendations or takeaways?
Yeah, so for younger people with obesity, there is usually increased lean mass. There's increased muscle mass, and the only good thing I can say about obesity is it does tend to protect you from osteoporosis. So for the younger people, we really do not worry. And for people who have higher weight levels, higher BMI, we don't worry. But the vulnerable populations are the people who start at a lower BMI and lose a lot of weight, and also older individuals. So, in the SELECT study, there was a numerical imbalance. It's in the label of semaglutide that there was an increased risk of fractures in that study, a numerical increase. Of course, the study is not really designed to test that, but I think it's something to be concerned about. I think overall, we think that the GLP-1 receptor agonists are achieving reduction in lean mass via the reduction in appetite. There are no GLP-1 receptors on adipose tissue. There are GIP receptors, but as near as we can tell, there's no difference in body composition changes with semaglutide or tirzepatide. Tirzepatide is a dual agonist to both GLP-1 and GIP. There's an emerging medication, it's going to be coming out this year, a long-acting amylin analog. And we're very interested in that because it's a dual molecule. It has amylin and calcitonin receptor activity. So we think that it may actually be a good choice for patients who are older, who are losing bone mass, or who are more vulnerable. So we'll have to confirm that, with studies. The drug is just emerging now. So we really need more evidence on that. But let me tell you, it is going to be the next big thing. Every company is investigating these long-acting amylin agonists.
Thank you so much. I think so. Something that was pending from the last question and that it really, fits here, I think, is in these patients, when should we refer them to a nutritionist? I know doing cardiac rehabilitation, it's hard to get approved for someone that is primary prevention, but do you usually recommend referring these patients for nutrition?
Absolutely. In all of the studies, all the phase 3 studies, that was available. It's written into the protocols, especially for people who are losing a lot of weight. Every person who undergoes bariatric surgery sees an RD. And they also come out of that with a special nutrition plan, and they come out with a special physical activity plan. Why are we not doing this with our medications that produce robust weight loss? For many patients, it's equal to the amount that they would get with bariatric surgery. So yes, we absolutely need to be doing this.
Yeah, I'd like to add, I'm getting enthusiastic. Donna's got me all excited here. So I completely agree with Donna. Also, Salvatore's fabulous presentation. The only thing I would add is more and more, and Donna knows this, more and more when we're doing these clinical trials, we're getting baseline micronutrients. Okay, so we heard about the importance of protein, ensuring protein. One thing I want to say that's the obvious, but the data supports it. When you put somebody on a GLP-1 receptor agonist, it really doesn't change the types of foods that they eat. It just means less of what they are eating. That's important because if they are on a lower protein diet, then yes, I think seeing a nutritionist and increasing the proportion of protein has been shown to reduce the risk of lean body mass loss, okay? But what I think is equally important, and in some cases more important, and this is what I mean, Donna knows this, when we're doing our trials now for all these new obesity medications, we're getting baseline micronutrients, which I'd never really done before. And yes, I read that 20% of people are going to have micronutrient deficiencies, but I'm like, is that really true? Folks, it's dead true. I'm talking before they even start their GLP-1 receptor agonist. It's remarkable how much, say, for example, vitamin D deficiency we know happens in patients with obesity. Reduction in calcium, we know. But I don't think people recognize that the inflammation associated with obesity impairs the intestinal absorption of micronutrients. So you have all these micronutrients that are down simply because people have obesity. You add to that the addition of a GLP-1 receptor agonist. Now, when it ended up, what started out to be modest amount of micronutrient deficiency now becomes a substantial increase in micronutrient deficiency. So what's the point? The point is exactly what Donna said, Dr. Ryan, is that having folks see a dietitian should be strongly encouraged, not for the purpose of weight reduction. That's what people get tripped up on. The purpose, when you're on a GLP-1 receptor agonist, particularly if it's a dual agonist or triple agonist, the focus of nutritional intervention is not further weight reduction. It's to improve or maximize the quality of the nutritional intake, including the micronutrients, and especially, and people have heard me say this before, I'm going to say it again, hydration, 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 hydration. The problem with GLP-1 receptor agonists is, yes, there's water in food, you decrease water intake, but there's some evidence that GLP-1 receptor agonists not just reduce hunger, but may also reduce thirst. So it's very common within our clinical trials to see patients GLP-1 receptor agonists where their creatinine goes up, their BUN goes up. Hydration, hydration, hydration. And then, as I said, really improving the healthfulness of the diet with regard to both micro and macronutrients, I think is all the priority in seeing a nutritionist, a dietitian, and maybe less so with regard to weight reduction. Donna, can I ask Donna, am I right or am I wrong?
You're right, Harold, as always.
That's not true.
Yeah. I do think the window of opportunity with these newer medications is the opportunity to improve diet quality. And Salvatore, you did such a great job on telling us what the best lifestyles are. Now we just need to implement it.
Thank you.
Yeah.
Excellent. Well, I think these were great last words, hydration, and make sure we're talking about diet quality, not just macronutrients or macronutrient composition. So I think this has been a really great session. Hopefully everyone has enjoyed our meeting today. I'm going to ask everyone to please fill out your post-meeting survey before you leave. Again, that gives us great information so we can continue to provide what you're interested in and what you need to know. And then I'm going to turn it over to my co-chair, Leandro, to bring it home.
Thank you so much. And again, I really enjoyed it. So hopefully you enjoyed it as much as I did. But before we finished, we wanted to leave you with some closing remarks as just to summarize all these amazing speakers that we had and try to wrap it up into some key concepts. So we learned from Mike Blaha of the difference between primary prevention, secondary prevention, and this continuum of ASCVD risk, and this middle group that we have through advanced imaging and CAG. So something that some people call this 1.5 prevention. We also learned from Dr. Nasir on when to use coronary calcium scoring, and in those patients that have borderline or intermediate risk, and how we can use a calcium score of 0 to de-risk in some of these patients, either postpone the initiation of statin or not use it for a while. But always, I would encourage considering the risk factors and not forgetting of the risk factors just because the calcium score is 0, and often re-scanning these patients later on. In those that have some calcium, but 1 to 100, usually with the New York guidelines, we also have some goals for target for LDL that I think it's a great improvement. And he reminded us of those that have a calcium score over 100, how we should be aggressive and use potentially in these patients some of the more higher expense medications if these patients don't reach an LDL target below 70 and even lower in some high-risk patients, where we can add PCSK9 inhibitors and other medications. We also learned from Dr. Joshi in the use in patients with type 2 diabetes that a calcium score of 0 can be reassuring maybe in the short term, but which have a lower threshold to rescan these patients. We saw that in chronic kidney diseases, it performs well across the different range. We keep hearing that the correlation between LDL cholesterol and the presence of CAG can be missed sometimes in the way that some patients may be labeled as having normal cholesterol, but still be forming plaque in the arteries. And that's very important to know. And that in women, CAG may start a little later, but it predicts the risk in a similar way that it does in men. And we had a brilliant talk by Dr. Shaw showing us how we can use CCTA for also quantifying the other components of plaque, not just the calcified plaque, but also how important it is to use this in patients with non-obstructive CAD. We published a statement in AHA about this, and we have now multiple softwares that are actually covered by the insurance and could be utilized in these patients. She emphasized the importance of this and the importance of using these softwares only in patients where we visualize plaque. And we saw also from Dr. Budoff how this can influence treatment, how we can visualize different components of the plaque, and in some cases we may even decide to track progression or regression of plaque and adjust preventive therapies. And we mentioned in the Q&A how we should be careful if we're comparing studies that we need to use ideally a similar scanner or the same scanner. Dr. Shaw reminded us of the importance of the KV when we're rescanning these patients. And when we're comparing plaque, we should use always the same software. But the good news is that we can track disease with CCTA and quantification of plaque, and we now have many therapies that we can use to halt or decrease this progression, where we lower the non-calcified component and we change the phenotype of the plaque into a more stable plaque. So we learned then from Dr. Bhatt on the importance of clinical trials to show that this approach using CCTA to guide prevention is is viable. And he told us about the Transform trial that we believe is one of the most important trials coming in the field, together with the Skull Heart trial too. And in this trial, this randomized trial, were patients who received preventive therapies according to the findings on the CCTA, and this will be compared to a group who are just using risk factors, and we'll see the effects on plaque progression and events as well. We wanted to include a lecture beyond lipid lowering, and we had amazing talk by Dr. Walton, where he emphasized on the importance of hypertension control as a marker for plaque progression and cardiovascular events. I think we're still not doing a good job in controlling blood pressure, and he emphasized how in the high-risk patients we should aim for a treatment goal of systolic blood pressure below 120, and how this can have a significant effect on outcomes. And we could use calcium score potentially to identify which patients beyond the prevent equation could have a higher risk to be more aggressive with the blood pressure control. We then turn into the amazing lecture by Dr. Fuster, where he talked about prevention in the young and how we could use vascular ultrasound to look at plaque, not only in femorals, but also in the carotid arteries, and how this could be a tool to visualize plaque early on. And he also mentioned how the other significant quest we have is to prevent dementia in the elderly, how we can start early on, how cardiovascular risk factors are tied to dementia, and how we can actually make a difference to change this. And he showed us some of the trials as he's leading to test this hypothesis and have some more data to push this. We also saw from Borja Ibanez how we can use ultrasound to measure the carotid plaque, and also in the femoral arteries, how this is essential for early disease and management, how we can use MRI for later composition of plaque. And I always like how he mentions that if we detect plaque early on and we treat aggressively, we can make a significant difference, but we often detect plaque too late. We saw from Beatriz Lopez Melgar how we can have significant addition on prognosis when we image beyond the coronary arteries. I think something in the US we're still underutilizing, and hopefully in the future we'll see more. And then we switched to something that we thought was very important to include in prevention. It is cardiometabolic imaging. From Dr. Bays, we learned about different modalities we can use to measure, how in many hospitals we could use DEXA. He told us in his hospital this is offered for a fee, and how we can use impedance also studies to assess different components, and some of the more advanced techniques like MRI that can be used but with less software to analyze it. And I think in the future, CT will also have a lot of tools to provide assessment of body composition. We saw also from Salvatore Carbone how we can act on diet. He suggests the Mediterranean diet. He mentioned also effects of DASH diet on plaque composition, and how we can, with this, make a significant difference in cardiovascular events. I think the clear message was that when we're using GLP-1 receptor agonists, in particular, we should refer patients to a dietitian to improve the quality of their food, and hopefully with that, improve their lives. And in an outstanding lecture by Dr. Ryan, we saw the future on obesity medications, and how we should emphasize also to avoid the sarcopenic obesity and reduce obesity in patients, and how in the elderly patients we should be more aware of the potential loss of muscle mass. And with that, I'd like to thank you very much for joining our symposium. We really enjoyed it, and we hope you had a great Saturday morning. And with that, we would like to thank you again, and to our supporters, Clearly and Heartflow, for their generous contribution to the program, as well to our amazing family that donated their time to be here. And with that, we can close the program. I'd like to bring Alison back to say a last few words.
Yes, thank you, Leandro. And again, thank everyone for spending your Saturday morning with us. I know I certainly learned a lot. I think this has been a wonderful session. And again, it's going to be recorded. What has been recorded, it's going to be available to watch. So if you enjoyed it or missed parts, feel free to share it with your networks, and it will be on aspconline.org, hopefully by May 1st or soon thereafter, as well as our YouTube channels. Leandro, thank you for doing an excellent job being a co-chair for this program.
Thank you, everyone. Bye-bye.